Maxillofacial School of Dentistry, our first study club of Maharashtra State Chapter AOMSI, Mumbai Division. This is the first study club organized by MSC AOMSI Mumbai. The study club intends to focus on giving young maxillofacial surgeons a platform to showcase their work and challenges faced in private practice in the field of oral and maxillofacial surgery. They also take a golden opportunity to learn from the vast experience the Starbucks Grand This study club intends, this study club will be held quarterly in our city. And we encourage all of you to come forward and actively participate in this initiative of MSC AOMSI. As we start with our scientific session, I would like to invite on stage our chairperson for this session, Dr. Gitanjali Mandle and Dr. Amit Dhate. Dr. Gitanjali Mandle is a professor of Diva School of Dentistry. She has been in private practice since last 32 years and is a consultant at Hiranandani Hospital, Bhavan. Dr. Amit Dhate is currently professor of OMFS at Diva School of Dentistry. I request our chairpersons to kindly introduce our first speakers for the day. Good evening, everyone, and warm welcome to the Wi-Fi. So, today's speaker for the day is my dear student, Dr. Vinny Pandey. He has completed his series from Wyoming Dental College in 2008 and his MBA from the School of Dentistry in 2012. He's a life member of AOMSI and Indian Society of Implantology. He has presented papers at multiple national symposiums and has trained as an implantology and advanced food therapy specialist. Welcome, Dr. Vinny. Yes.
Good evening to one and all here. Thank you, ma'am, to introduce me. Please privileged to be introduced by your PG gallery here today. On the outset, I would like to thank Neil. I'd like to thank the AOMSI and the Maharashtra State Council to have me as the curtain raiser for the evening today. As the practice controversy and consensus is something that we will be discussing on. The disclaimer says I would not be going through the theory discussions at all because we have another PG convention coming up soon and I really see all the practitioners here. Sorry for the compromise with the colleague because I'm sure the young oral students here like me would know how difficult it is to maintain records when the staff is taking. And there are some online pictures that I have used, but that is only to describe and discuss the basic concepts. So we see a little theory where we know the fracture pattern is generally when there is a trajectory force, there is compression and tension which leads to the fracture of the mandible. Roughly going through biomechanics, there is occlusal load which leads to tension and compression zones, and hence we know that we have Chantilly's lines, which is a neutral zone where we get the aim at plates. But what is important clinically is what type of fixation we as surgeons are going to put. So we have load sharing and load plating, the two techniques that we will be using. So in cases where we have a good amount of parent bone, the both sides of the fracture line, the bone is strong enough, which is going to take maximum amount of load. That's where we will be putting our mini plates so that the load is shared by the bone and the plates and not only by the plates alone. Whereas when it comes to load bearing, we know the mandible segments are weak and we want our plates to be strong enough for to take the load. So coming directly to some of my cases, Ankit, this boy, 16-year-old, he was playing cricket and was hit by a ball, and he was all okay because as we see even from the X-ray, there's no major malocclusion that we can see, but there was pain which was lingering for a week, and that's how we came to my OPD. So seeing the OPD, I decided that okay, there are two fracture lines, so we got to plate it. Simple interval approach, we take care of the neurovascular bundle, we take an angle also to intraoral, we have good bite, and we close it, and that's how we see the pre-op, the immediate post-op, and with a 2-year follow-up roughly. And that's the time when you're really happy, and the team is also happy, patient is happy, when no scar lines, nothing. You really feel good about it. But when it comes to condyle fractures, when you see your X-ray something like this, that's where you would have mixed emotions. One is you're excited that you are surgeon, you're going to be operating it today, maybe it's an external approach. At the same time, on the other end, you're confused that you'll be doing closed reduction, open reduction, you call up your contemporaries, your mentors, and you try to find out what is the best treatment for it, but eventually you do what you have. So I'm not going into details of the different classification systems that we have, but roughly condyle fractures you generally describe them as neck fractures which are high and low, and subcondyle which is below the neck. And other than that, we see the fracture segment whether it is within the fossa, whether it is displaced out of the fossa, whether there is any medial or the lateral overhang, and that's what you need to decide what is the treatment plan ahead. So close reduction as one of the treatment, it is the functional adaptation of the mandible. So this would be achieved only when you can get a stable occlusion over there. Of course, it's minimally invasive. You just inject local in and around, and there's no hospitalization basically required. But the disadvantage is that there will be a longer time of IMF. You would disturb the growth in children, and when you don't have this good dentition, it will be a challenge because you can't put your arthros and wires stable. So basically, only when there is undisplaced or incomplete fractures, which you can achieve occlusion without much of manipulation of the mandible, or a medically compromised patient where the physician says that it's better to avoid GM, is when you would really look at dose reduction. But other than that, I would always recommend open reduction because you would achieve anatomical fixation. These are the different types of plates that you can use. And when there is gross occlusal derailment, I would of course recommend open reduction. Like we see in this case, there's a reduction in the facial height, and there is occlusion also which is disturbed, and I'm sure this cannot be achieved by close reduction. So we would go for open, and in open you would select your approach as comfortable, being retromandibular, submandibular, or preauricular. Also depend on where the fracture line is. That's where you should decide first. Access from. Coming to this case where the condyle fracture was seen along with the opposite side angle. So we always, I always would recommend to mark the mandible, mark the anatomical features which you are going to be saving from, and mark your incision. Always go to basics so you are not messing up on any of these structures coming on your way. Ease for you to reach up to the fracture and plate it also. So that's how we went ahead for the plating in this case. And that's what we see the pre-op occlusion and the post-op occlusion. We could achieve quite a good amount of reduction. Coming to this case shift, he had a fall from his cycle. So that's when he got some bruise on the chin, on the nose, and that's when we do his CT and then OPT find out there's a fracture line present over there. A simple, straightforward, load sharing kind of plating, two plates at the left contact, and we could really achieve a good fixation. Some of the similar cases that I would not really like to get into because I'm sure all of us would be doing this on regular basis with two plates at the surfaces, at the body, at the angle, or at the contact. You would be going through this. But what when it comes to comminuted fracture, like this case of Jared, he had an RTA his mandible, his occlusion, where you can see in this picture, has been totally derailed. We see there's a sublingual hematoma that is quite big enough. On doing a reconstructed CT, we can see the fragments at the symphysis region. I'm not sure if this is clear hidden, but there are quite many smaller fragments which are here. Of closer view, we can see it's totally deranged here and the fragments are around. Now, in this kind of case, if you go for a mini plate fixation, you would never get stable plating because there are so many fragments that you would not be able to put your screws, put your plates there. So, this is another case where you would be going for a load bearing kind of plate where these smaller fragments you can save them, take an external approach so that by going intraoral you'll be stripping off the periosteum, the blood supply of these fragments. So that is when you would be avoiding all these bone and they would die eventually. So rather than that, taking an external approach, in this case of course there was a CLW, so that was extended enough and a plating was done. The smaller fragments can be held to this plate with sutures passing around it. So as it heals, it joins all over. There you can see the plate is nice adapted and it has healed well. And that's how the occlusion is after 2 months. You see there's complete healing of the sublingual hematoma as well. This is one of the cases where you would go for load bearing kind of plate. Complications, if you are a surgeon, if you are operating well, this is how you would be facing complications. You can't run away from them. You should not get angry, pissed, nothing. You would have to be by your patient. They are your complications. You got to face it. We all have it. We're discussing one of my case. 78-year-old aunt. She is wheelchair bound. She generally walks with a walker at home. Unfortunately, that one day the walker was a little away and she tried to catch it and she had a fall on her face. This is a year back before the fracture, nice and smiling, healthy auntie. You see down the line how she suffered the uneventful fracture. So when she comes, she is referred to me by the GP, and fortunately, the GP told you got to go and meet a maxillofacial surgeon. When in this field, we had ENT plastic surgeons all jumping into it. The doctor was told the patient to meet a maxillofacial surgeon. So coming to me, I saw this X-ray. I eventually took out the GA. That's how I opened up, and that's what I see. The mandible is this big. Like I'm sure it was smaller than a little finger, as small that I couldn't reduce the fracture that easily. I tried to go in with intraosseous wiring, but even the fracture segments were still mobile. Eventually, I went to the inferior border and I put two plates. Looks quite stable on this post-operative X-ray and quite good otherwise. But what happens at 45 days, because she was wheelchair bound, I didn't follow that often for follow-up because she was too consecutive weeks to me. Beyond that, the son calls me that there's something that has come up in her mouth and there is some swelling. Now, when I ask for an OPG, that's what I see. The plate has moved, the screws have moved, and that's where the bone fragment is seen intraorally. When I do a CT, that's when I realize that there was some fracture on the left side, which was never seen before, has been there. That's what I appreciated on the CT cuts. So considering this, after this, when I recommended her to go ahead for the second surgery, it was real turnaround because we were mid-second wave of COVID. She got COVID, she's eligible diabetic, she was hospitalized. With all this going on, she could bear with this and she was quite happy that I don't want to get surgery done. But on repeated convincing her that this is not the way of life that we want to lead to, that's where I scheduled her for corrective surgery. Take an external incision now, expose the old fracture area which was there, remove the old plates, put a load bearing recon plate, attaching it to whatever was available around, and fix this plate back, suture it, and that's how she looked 1 week later. So that's where I started from. That's what came to me. To my surprise, there was some fracture here which I missed, that's on CBCT. And that's where I have treated it. So complication we would have and we should plate it enough. And I'm happy that she could bear with my complication and she has healed and smiling now. So that's what I would like to conclude with, that certain things we should not be missing out on. We should stick to our basics. Whatever is required is required. Take a proper history on how it has happened, what has happened, And I'm sure that will give you a lot of insight on how you should be going ahead, like how she's had a call, how the person has called, where you would see the practice. Maintain all records, consents, everything in order. You never know when what is required. Like I repeated CT after I saw my complication, I would recommend to use all advanced imaging techniques, whichever you feel are required. Don't shy away from whether I should advise a CT, whether the patient would run away or go to other surgeons. What is required is required. Don't be shy to discuss with your mentors and colleagues. It's always better to discuss out, and that's when you would be getting a lot of insight about how to go ahead. We should never hesitate to take extra decisions. Don't be scared. Learn your anatomy, learn your incisions, you will go quite inside properly. Predicting complications, like in this case, I did predict that the plates would move, but during that time, I had no option, but I could plate only those two small plates over there. So prepare what complications will be there and how plan B in your mouth, in your mind. And last, I think it's written there. Stand by the patient always. There are complications that you could face, but you should stand by it and see to it that you are correcting it. I would like to thank sirs to always be my best, be on my side, even to trying times and to be my friends. That's me. Yes.
So nice presentation,
Thank you.
Dr. Vinny, and your Viva starts now.
Yes, I'm ready for it.
So any questions? So I have a question. So this last case which you showed where you have faced that complication, what is any other method that you could
I was prepared for recon on day one itself, but the mandible was too thin. So when I started, I opened, I stripped off, and that's when I realized that it's too thin. I should have plated the recon directly, but when I was on day one, when I was trying to do it, the fracture segments were just not ready to be there. Maybe gunning splints, but her dentures had also fractured really bad because she was wearing
So
dentures
in
in
such
chest.
case, I think you should be a little bit more confident. So that is the strip of the solution. I think that would have been a
Better.
one option.
I thought since the dentures were broken, so I would not be able to do that. But yeah, gunning splint was one of the options.
That's it. The total amount that was available, I think, was not enough.
Very.
What is the road there? Actually, the amount of phone is so
Amount of phone available was not much. Yeah, basically the concept is less responsibility so that you have to
Yes,
perfectly.
Right.
So in that case, a conservative approach would have been a better option. That's what
especially they can enter the patient. That will be the problem. They
I'm
can
saying. The broken.
they can go mistakes. That is an option.
So thank you, Dr. Vinny.
Thank you
So
so much.
nice having you here.
Thank you.
Yes, next speaker for the day is Dr. Chinmay Rao. He has completed BDS from MGM Dental College, Navi Mumbai in 2011, MBS from BSCM Dental College and Research Center, Nagpur in 2016. He is a PhD scholar. He was awarded the Dr. I.C. Gudani Gold Medal. Currently, he is working as a lecturer at the Department of OMFS, MGM Dental College, Navi Mumbai. Please welcome Dr. Chinmay Rao.
Thank you so much. A kind of request to the audience members. you see a certain code on the screen. I want you to open up your browser if you can. Your browser on your phone. Can quickly do that. Open up the browser on your phone and go to the website joinpt.com and put in the code LHURIL. I repeat, go on the browser, open up joinpt.com and put in the code LHURIL, no spaces, LHURIL. Already have 9 people joining in quickly. Mind you, there is no login required and your answers are going to be anonymous, so don't worry. Okay, while people are joining, let's quickly start off. You can still continue with me. Okay, thank you, MSC AOMSI, for this opportunity and of course the organizing committee at DY Patil. I'll be talking on the controversies of you on matrix, and my primary idea is going to be trying to come to a consensus at matrix factors. I know it's next to impossible to have a consensus in matrix, but let's try. A quick disclaimer: the recommendations that are part of this presentation are evidence-based and they are specific to those cases. Please extrapolate wisely, check your evidence before. The endeavor here is to highlight controversies in the management of factors of the matrix according to analytical subunits. The present existing evidence is what I'm going to talk about. This is an attempt to try and have a consensus. I have no financial conflict of interest, and these recommendations will not include measures specific to COVID. Going on, just a quick brief about the audience poll that we are going to have. You're going to get about 15 seconds each. Once you see the question, I'll tell you that this is a question. At the lower right corner of your screen on your phone, you will have an option called answer question. You can answer it, and in about 15 seconds time, you will see the code. Okay? Let's go ahead. We'll be talking about these aromatic complex factors first. Okay, so look at your phones and let's quickly try and answer this. How many points of fixation are adequate in your opinion to achieve a functional stability of these aromatic complex factor in this case? In this case, the lower right corner you will find options. 28 people have answered. Let's go. Last 5 seconds left. Okay. So I'm locking screens. Okay. So a vast majority have said 2-point fixation. There are a few who spoken of 3-point fixations, and of course, some people have also preferred close reduction in this case. So let's get a consensus. The reported data with systematic reviews says that there is a superiority in 3-point fixation. Of course, 2-point fixations can also be stable, depending upon the cost, the operative time, and the exposure of failures to stripping. We may have to consider either a 2-point or a 1-point fixation. Now, when it comes to systematic reviews and meta-analysis, please remember, just because it is a systematic review and meta-analysis doesn't mean that it is good. Now, like in this case, it was a journal of oral maxillofacial surgery 2019. They have chosen 2 randomized trials and 11 case series. Trust me, 11 case series and 2 randomized trials is not at all good evidence. Okay, just because it is a randomized controlled trial and just because it is a systematic review doesn't mean it's good evidence. This at best is only partially good evidence. Another journal here, now the British journal in 2022 says that there is no clear conclusions that can be drawn. Basis the stability, repositioning, and post-operative complications, based solely on the number of fixation points. So again, it's a case-by-case basis. They have particularly said that the use of intraoperative CBCT or other intraoperative techniques can really help you. Okay, so that's something to keep in mind. Again, the age-old Manson's pointers here, the pointers for alignment and pointers for fixation from left to worst. I guess we are all aware of this, so let's go ahead. Now, again, in your phones, what will be your choice of material for internal fixation of zygomatic fractures? In your phones, about 5 seconds left. Okay, let's see responses. Titanium through and through. Almost everyone says titanium. Great. So, there is no difference in the appearance of injection diplopia and paresthesia. This is the choice of impression material. Resorptive plates have been shown to have better so-called clinical performance post-operatively, but still the jury is still out there, right? Coming down to Laporte fractures. Okay, in your bones again, do you commonly use IMF to supplement your fixation in Laporte bone fractures? Let's have a poll. Do you commonly use IMF to supplement your fixation in Laporte bone fractures? Last 5 seconds. Okay, good. Let's see. Okay, again, overwhelming majority does use IMF, right? So that's I guess all of us we do that. So according to this article, one major pointer that we can always consider is whenever you are using IMF, please remember that it is important, in fact, imperative to clearly mobilize your fracture in case you are not able to mobilize, in case you have an anchorage still. You may end up, especially where the fracture has impacted more anteriorly, you may end up having the IMF in a more anterior position, and when you end up releasing your IMF, you will have the mandible go back to its original position, and you may actually end up with a clash to point, right? So that is something that we always need to take care about. Coming to mesoorbital ligamental fractures. Okay, so looking at this CT in your bones again, what kind of anesthesia would you use for the reduction of such a nasal fracture? What kind of anesthesia would you use? About 5 more seconds. And that's it. Let's see. General anesthesia is the answer. Majorly, people say general anesthesia. Great. Let's see what literature tells us. Now, here, according to a review back in 2009, they say that local anesthesia is safe and effective. Right? So it can be a safe alternative to your general anesthesia, especially for pain relief during fracture manipulation. And they found that there was no evidence of inferior outcomes. So local anesthesia works. Now, what is the advantage of using general anesthesia? General anesthesia provides you better patient satisfaction. And most importantly, if you are able to achieve adequate exposure with your general anesthesia, and because of the amount of comfort that you have when you are operating the general anesthesia, you don't have the patient squirming under you. At that point in time, it decreases the number of subsequent corrective surgeries required. So you can go in and do a good primary repair so that you don't end up with a secondary deformity that you end up having to operate again. So in that situation, of course, GA is a better choice, but LA can work. For minimally displaced fractures, LA is a good option. Now, will you use internal fixation for such nasal fractures or injuries? In your bones, will you use internal fixation at all? About 5 more seconds to go. You are anonymous, so does it really matter? Okay, let's see the responses now. So we do have a close call, but yes, most of us have said yes, we will use internal fixation. This was my case from a few months back, and this was the patient 2 weeks follow-up, close reduction. I have not used any internal fixation implants here. So what I basically did was ended up switching everything back in place, put in internal nasal packing there with an external splint. Nasal pack was out on the 4th day. External nasal splinting was out on the 2nd week, and this was the patient 15 days. I have seen the patient again at 2 months follow-up. This is exactly the follow-up that I have. So internal fixation is not always required. Looking at orbital fractures now. So this is one of the cases that got referred to us back in MGM. When is the right time to intervene for treatment of orbital fractures? Again, in your phones, when is the right time to treat orbital fractures? Seconds. And they good. So immediately 2 weeks, if you say 2 weeks, if you say secondary corrective surgery, I see dynamic changes here, so let's not change our answers. Okay, there are still changes. Okay. Okay, so evidence supports immediate repair. When it comes to delayed repair, generally there is no clear consensus as far as delayed repair goes, whether it is a 2 weeks or a secondary repair. Jury is still out there, but as far as immediate repair goes, if it is possible, if you see the patient early enough and the edema is not settling yet, you may actually attempt immediate repair. Does the size of the defect have a role to play in orbital reconstruction? Again, in your phones, does the size of the defect have a role to play in orbital reconstruction? About 5 seconds more. That's fine. Yes, it does. Of course, it does. Great. So, I have a follow-up question to that. What are the indications of surgical intervention in orbital fractures? Now, if you see the options, almost all of them are indications, but in your opinion, which is the most relevant indication? Okay. So, what are the indications? From the options, almost all of them are relevant, but choose the one that you think is important. About 5 more seconds. Okay. So let's see responses. CT evidence of entrapment is by and far considered to be the most important evidence, and I'm seeing more people answer that. Okay. So it's a biased answer who was answered, but yeah. Positive post-rupture, of course, enophthalmos not so very true. So let's see what evidence has to say. So according to this article, it was one of the better articles during a systematic review. They have classified defects into 4 categories, vital defects into 4 categories, and generally accepted indications according to what they have said, what another worker has said, is a positive post-rupture test or persistent diplopia with CT evidence of entrapped muscles. Now, along with that, overall, a combined fracture like an orbital floor with a medial wall, with the loss of the medial strut, can be considered as higher risk, and we would of course want to go in open, right? Currently available studies which are analyzed for the systematic review, and it was found that data is insufficient to provide a robust basis for clear guidelines solely on the basis of the defect. So again, this is again what I'm talking to you about systematic reviews. Systematic reviews, they have considered 232 articles, but look at the retrospective studies, 270. So actual randomized trials and controlled clinical trials is a negligible part of the entire review. So practically speaking, systematic reviews not always do they make sense. Okay. So again, evidence with a pinch of salt. Be very careful. Treatment algorithm, as these guys have proposed, uh, you can go from resolvables right down to prevent and patient specific implants, depending upon the class of fracture that you see. And additional factors that may influence your choice of implants are, of course, the cost and simultaneous irregular amongst the rest going on. So this was how we treated the previous patient. He of course had a formulate there that the ophthalmologist ended up operating. Unfortunately, this patient lost vision in that eye because the amount of injury to that eye. But we were able to get at least a functional closure. In closing, this was one of the cases that we did at our institute about a year back. This is where we combine virtual surgical planning with analog methods, where we had a sugar already vein fracture, which led to a certain amount of putting as well of the upper eyelid. We basically got an SPL model who mirrored the fracture onto the fracture surface side. We ended up pre-bending a titanium mesh, blocking out the mesh, made an impression out of it, and ultimately got a cast. So eventually we ended up making a vacuum splint, which we used intraoperatively. And here you can see the splint is clearly sitting over the defect, and we have achieved beautiful recontouring. You can of course see the defect below the mesh clearly, and this was the post-operative. We were able to achieve. So all in all, the fact that an opinion has been widely held is no evidence whatsoever that it is not perfectly observed. So please go with evidence, try and do as much as basic research as we can, and always go with your mentors, your seniors, they've had the experience that they have, and combine everything and then go ahead with your work. Is all that I'm trying to say. Thank you again for the opportunity. Thank you all.
Do you have any questions?
We will continue with the scientific section after inauguration. Third speaker. We would like to continue, sorry for the interruption, we would like to continue with our scientific section. Let me call on Dr. Aditi for demonstrations. So our next speaker is Dr. Aditi Ram. She's completed BDS from MCOBS Manipur, MBS from SDM College of Dental Sciences, Harvard. She's a member of AOCMF and has been selected for prestigious Young Surgeons Fellowship program in orthodontic surgery in South Korea, a certified implantologist for international teams for implantologists.
Thank you, ma'am. Thank you so much. First and foremost, thank you to the Diva faculty for giving me this opportunity as a young surgeon coming out and talking about our own experiences in such a young age is absolutely a privilege. So today our topic is scientific fractures. Scientific fracture is something that is controversial from the name of it. We don't know the definition of scientific fracture. Some suggest it could be only 2/3 of the face being fractured, maybe the upper face and the middle one, and most of the consensus is about all the three fractures of all the thirds of the face. So pancreatic fractures are most challenging for all of us, including the surgeons, the anesthetists, as well as the patient. There are different degrees of fragmentation that is there in a pancreatic fracture, because of which it is very difficult to restore and give a proper form, function, and aesthetics to these patients. The most common reason for a pancreatic fracture to happen is assault. That is what is being proven through a lot of studies that they have performed, and they have found that 43% of pancreatic fractures is because of assaults. We also have a motor vehicle collision. When there's so much fragmentation happening in the faces, it has to be a high energy fragmentation, a high energy fracture. And that's the reason for assault. We have a lot of patients who come with a lot of interpersonal violences, which should lead to assault and a lot of pancreatic fractures. The most important is the initial examination of these patients. These patients come to us with absolutely unsecured airway. And when we call you, there's a lot of bleeding in the patient and you don't know how to treat it, how to begin with. You don't know what you're getting into. The first thing is to secure the patient, and airway is the way to get there. Oral intubation is what is usually used in the trauma ward. As soon as you come to trauma ward, we will put an oral intubation and see what to do later. And this oral intubation is later converted into a submental intubation during OT. So this does not come in way of your occlusion, and it helps in proper treatment of these patients. You can also go ahead with a nasal intubation, but we don't know if the nasal bones are fractured until we do the further examinations of these patients. The next thing that comes is bleeding. These patients come with, this is one of the patients who came to us. Her husband banged her head on the wall many times, and this is how she came to us with severe bleeding and absolutely disoriented. So the main reasons for a patient region to bleed, the main things are the tongue, the scalp, and the mid-face. So either get stay sutures for temporary purpose so that the bleeding is controlled for that point, nasal packing, and then you can go ahead with what has to be done. It is very important to involve every other specialty. Though we all want to do everything by ourselves, but it is important to call your senior, call every other department who is involved with this pancreatic fracture for the best for the patient. Coming to imaging modalities, before we used to say plain radiograph should be enough, but pancreatic fractures are really minute bony fragments, and having only a plain radiograph is absolutely not helpful. Today's CT is there, which really helps. Coming from 5 mm, which was there before, Today it can come down to 0.5 mm cuts, which help you also build up a 3D model in which you can plan your entire surgery. Clinical features, I'm going to rush through this because everyone knows the clinical features that a patient will come with maxillofacial trauma. Basically, a cranfacial clinical feature is everything, anything that is fractured in the face. If you have the mandible, all the symptoms you see in the mandible, you will see in the panfacial. Mid-face, you see in the panfacial as well as the upper face. This patient has facial edema, lot of soft tissue injuries, lot of bleeding, bilateral subconjunctival hemorrhages. You can see that the horizontal buttress in the NOE region is very delicate, and fracture of that will cause impaction of the region. And you can see the nasal tip projecting, the entire thing is gone down. When the entire mid face is impacted inside, you see a dish face deformity in these patients. There's orbital dystopia because it's one-sided fracture. The intercanthal distance will be increased. The facial widening will be there because the entire structure is broken and they all start coming towards the medial region, because of which there is a facial widening that you see, and of course you're going to see malocclusion. We all know that our face is made up of a lot of buttresses, and this buttresses is absolutely required. They're thick bones over which your entire soft tissue fall, and they give you an amazing projection that you have to the face. And in a panfacial fracture, everything is fractured, and you have no reference points to create any of these. However, it's important for us to know the buttresses. You have the vertical buttresses, the nasomaxillary, zygomatic maxillary, pterygomaxillary, and the condyle and the posterior mandible. You have the horizontal buttresses, which will be the frontal bar, the zygomatic, the maxillary, and the mandible. When you restore all of this is when you get height, width, and projection for the patient, and this is what you have to achieve in every panfacial case. Coming to the most controversial thing about panfacial fracture is sequencing. It is every surgery you go to will say, no, I will start from top to bottom. Others will say, I will start from bottom to down. Some will start from outside to inside, and some will start from inside to out. There are a lot of options that are available when it comes to sequencing. No one knows what is right, what is wrong, and this is the biggest controversy when it comes to sequencing. And this led to these four main options. Most of the surgeons worldwide have adjusted to. There's a consensus about these four, which is top to bottom, where you start from the cranial region and come down caudally, or you go from bottom, making the maxillomandibular unit as a block and then build over it. You can come from inside to out, where they build the central region first and then make the outer frame, and outside to in, where the outer frame is built. There are also articles which suggest sequencing in the name of simple to complex and known to unknown. These are the authors who say that go from something that you know how to handle, go from something that is easy, and then go to something that is complicated. Coming to one of the articles that had a systemic review of all these articles who mentioned different forms of sequencing, and they came to a conclusion that the most widely used one was bottom to top outside in, or top to bottom inside out. So these were the two schools of thought, and after this review, where they reviewed around 88 papers, which was published in all the medical journals all across, and they came to the consensus that the bottom top outside in is one of the best treatment plans for the patient. Maybe because as our basis is dentistry, we love this occlusion, and we want this occlusion to be achieved. Because we all know that patient is going to come back to us saying, I can't eat, and he will not care about anything else. And this is where we have to begin, and that's what most of the authors said, that we are good with dealing with this, and if we start from here, it's easier for us to build up there. There was another article who did a comparative study of all these sequences, and he basically used only two sequences, that is bottom up and top down, and he did a random study around, but his sample size was very less. He did around 15 patients, but he came up with a conclusion that both of them were very similar. If you had planned it well, and if you go across with what has to be done first, he came up with that both of them were absolutely similar, and it is up to you how you started. The other controversy that lies with panfacial fracture is the ideal treatment for ideal time for this treatment. When do we operate on panfacial fracture? As you know, when a panfacial fracture comes to you, they're very steady. The entire face is blown out. So obviously, an early intervention will give us proper facial contouring because the bones are not remodeled, the edges are proper. You tick and they will click together. There is no scar tissue, there is no callus formation. And the late intervention obviously will have callus formation, there will be fibrous tissues, there will be scar tissues. So obviously the repair is going to be much difficult. But this is not always in our hand. There are some times that the patient has to undergo a delayed treatment because of an unstable medical condition, or he has intracranial injuries, he has a lot of things happening along with the panfacial fracture. The patient very rarely comes with only face gone. There are a lot of things in the body that's gone, and he really needs the other assessment. Also, another article also said that there was a failure and a lot of complications related in early intervention if you did it before 2.5 days when there is a lot of edema in the patient's face. So there is a lot of edema. That also suggests that you should wait, give him antibiotics and steroids, and wait for 2 days and then operate on the patient. You'll have better results. Otherwise, you'll get a lot of complications. Goal for any panfacial fracture: anatomic reduction, absolute stabilization, undisturbed healing, early painless function, and of course restoration of the overall configuration. The author suggests the two things: bottom up, inside out, and top down, outside in. We'll go individually. When it comes to the mandible, they suggest, all the authors in every paper suggest that first make that maxillomandibular fixation. Get an IMF. MMF, you have the entire occlusion set. In such cases, it's more difficult to get an occlusion because there's crowding there in this patient. But in any condition of this, also you are supposed to get a proper occlusion, the maximum intercut that you can get, and then go ahead. With this, sometimes you have a palatal split that will be present in the patient. If there is a palatal split, then the palate is facially grown away from each other, and there is a facial widening that is present. And if you go ahead and just do an IMF without correcting the palate, then the authors say that you will have a tough time because that is not the occlusion that you are expecting to have. So when you're going from bottom to top, they expect you to do a palate first, do a normal palatal. You can give a small plate in the palatal region. If you don't want to open a palate, you can take impressions before taking the patient to the OT, make splints for the patient. So you have splints, and then you can go ahead and do an IMF. Followed by condylar fractures, which have to be attended first. Condylar fractures will help you get a posterior height of the patient, and it will make you will have a relationship with the skull, and that is your posterior height. And then go ahead and do the symphysis and body fractures. So this is the bottom top, and you know that you have to address from one condyle to the other if you want to make this as your base for your entire panfacial fracture. So if this is your base, then the condyle to condyle has to be adjusted, starting from the condyle and then coming to the symphysis or the parasymphysis region. However, doing all this also, there are problems that are encountered according to all these articles, who say that there's playing of the lingual cortex. Usually when you're reducing intraorally, and you're reducing the buccal surface, and if there is bilateral subcondylar fracture, then because of the muscles, the mandible is going to get widened. And only the way to get out of that is to get an extraoral incision and get a lingual cortex, or make an anatomic reduction lingually, so that you know your anatomic reduction is exactly right, so that there'll be no splaying, and your dimensions according to your width will be proper. There'll be malocclusion. If there is malocclusion, your condyle is not sitting properly. Make sure to get the condyle right. And if the maxilla is impacted, make sure to get a disimpaction of this before you do an IMS. Coming to up down, when you're coming from up, the frontal bone, if you're preparing that first, then you know that they are making a base for your mid face, and you have to address everything that is in the frontal bar region, the frontal sinus, the supraorbital rims, the orbital roofs. They all will make a foundation for your mid face. Coming to if you're doing the top down, then you start with the coronal incision. This coronal incision will help you reach the frontal region, the FZ region. You can reach the condyle if you extend your incision, and the zygomatic arch, if has to be plated, then you have to go through this region. The complication that is arised over here is that obviously there will be a dipping in the frontal bone, and you will need bone grafts to repair it. Coming to zygomas, zygomas have to be elevated completely out, and you have to make sure that with bone hooks that they are not rotated back, they get in the right position, and only then can you fix it. To start with this, it's better you start with the FZ, which will give you a proper reduction of the zygoma using the sphenozygomatic suture. Difficult to plate. Usually, most of us don't plate it. We do the FZ and then we follow. This is the same thing for the projection. If there is a buttress collapse in the zygoma, then you'll have to do a bone grafting before you close this case. This is one of the cases where there was already a laceration present. The laceration was opened up and complete fixation was achieved. Coming to orbital fixation, again a very important point where orbital rims are fixed first, making a complete structure ready, and then the volume has to be made sure to be attended. If you leave the volume with that, it's very difficult for it to be corrected at a later stage. Secondary surgery for anatomy is much more difficult. It is better to go ahead and do it during the panfacial surgeries. Coming to nasoethmoid, this is again, this needs a frontal bone that is stable and the ZMC which is stable so that you can fix the NOE properly. And if there's complete depression of this region, which is highly possible because the buttresses over here are very fragile. They don't have a horizontal buttress. There's just one vertical running from there, and it does not support much, and this will cause fracture of that region and the depression. So you will have to do a primary bone grafting, and if required, you'll have to do a cantopexy for on telecanthus based on what is the type of fracture. Coming to the challenges that a surgeon faces during a panfacial fracture, when you're disimpacting the mid face, there are high chances you will have profuse bleeding that will arise over there. That's because when the maxilla is being impacted inside, there might be some tear, something there, and because of the impaction, it is still okay. As soon as you disimpact it, that will tear more, or there'll be new blood spurs that will start and there'll be profuse bleeding. So before surgery, make sure these coagulopathies are sorted for. The orbital volume, again, as I said before, you have to make sure that the orbital volume is taken care of. The entire posterior mandible, when it falls behind, when you have the entire maxillomandibular complex impacted backside, there are high chances of the retrograde fall, and the tongue will fall, and the patient will have altered breathing. This can also affect speech. There will be lid laxity because of the complete degloving that we will be doing. So lower eyelid cantopexy is required. The other consensus that people have arrived is that for proper facial aesthetics, it's required to have a deep closure and resuspension. It's very important to have a closure in these patients because facial aesthetics is what we are achieving. At the end, if you're telling the patient, no, your zygoma is in the proper place, but the cheek is sagging, he's not going to be happy with what you have done. So make sure to go ahead and do a deep closure and a proper resuspension in the orbital rim region. Make sure the periosteum is sutured. If there is not enough periosteum, make sure to take deep suture through the muscles. The lateral canthus, there might be a slang in the canthus. Make sure to do a cantopexy. Mentalis muscle, make sure to do a dressing post-surgery so that the mentalis heals well. Deep temporal fascia, there might be a hollowing if the temporal fat pad is of your treatment or your reflection, so suture them properly. We ran through the cases that we came. Subhash is 46-year-old and panfacial fracture. We started with the mandible. The mandible was fixed, followed by the FZs bilaterally. Bilaterally, the FZs were fixed. We came to the ZMC, and the NOE region was fixed with 2 plates bilaterally. This is how Subhash came to us with, and we have plated, and he's responded very well to the treatment. This is Manjunath, again, one more case, 32-year-old, a motor vehicle collision. In this case, bicommunal flap was raised, the frontal bone was elevated and a FZ plate also was placed through this incision. Bilateral ZMCs were treated along with the orbital rim which was covered, and then finally coming to the mandibular complex, giving the mandibular body to plates. Sandeep, 28-year-old, just before COVID, came to us with interpersonal violence. He fractured his frontal bone, extremely comminuted fractures. We fixed as much as we could all the larger particles and we placed a mesh. The ZMC was treated with 2 plates. Sorry for the peak, there's one more inside. And finally, the mandible was fitted. The patient had good occlusion and he's doing absolutely all right. So panfacial is absolutely challenging. It's controversy from the name of it. It is advisable to go step by step, and panfacial is nothing difficult to achieve. If you know how to individually manage a fracture, then you know how to manage a panfacial fracture. Thank you so much.
Thank you, Dr. Aditi. Nice presentation. Any questions, please? I just have one question.
Yes.
What is your choice of sequencing?
Bottom to top. Thank you.
Thanks all the speakers for an informative session. Now I would like to invite Dr. Vaishali Dasman to participate as chairperson for this session. Dr. Gaurang Mistry, Dean of Devasata School of Dentistry, to participate our speakers for today. Dr. Neil Pandey, Dr. Chinmay Rao, and Dr. Aditi Bhatt. Dr. Chinmay Rao. Dr. Aditi Bhatt. I would also like to thank our sponsors, VR Auto, SM Surgicals, Auto Max, and Surgicals. We would also like to thank Mitra Infotech LLC for the technical support. Now we would like to begin our economic segment. I would like to invite Dr. Gaurang Mistry, Dean of Devasata School of Dentistry, Dr. Putin Padre, Dean of Faculty, Dr. Yogesh G, Deputy Department of OMFS, and the senior Maxillofacial surgeons amongst us. Dr. A.K. Chitre sir, Dr. Pushkar Paragar sir, Dr. Ashok Datti sir, Dr. Jyotsna Ravindran ma'am, Dr. Himanshali Mandri ma'am, cited a lack of knowledge. Dr. Sunil Shah, President MSC AOMSI, and Dr. Anuj Gade, Secretary MSC AOMSI. The request of the Sir and Council to address the esteemed audience and those who joined us online the YouTube channel. So you are online.
Hello. 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 Good evening. Can you hear me? Hello. I hope you can hear me. Hello. Yeah. With all respected seniors, teachers, and all senior people, I could see there gathering together in DY conference hall. Uh, I give my complete support and this to young people, Pranay and Aishwarya. Uh, this was an idea of this state team to conduct small study group circle to bring young surgeons together in the flow with the big guns, and we have a good bond in between the seniors and juniors, and probably uh, get this study club concept going well to get better integration between our brother OMFS people. So I hope that Bombay is doing this second meet today, and Pranay and Aishwarya has done a tremendous job. I thanks all. Probably you all can hear me. Thank you. Thank you for requesting me to give this kind words, and all thanks to all the seniors who have joined there for today's show.
Thank you so much, sir. Anuj, sir, you are live now.
Yeah, am I audible?
Yes, sir, you are.
Yeah, you are audible.
Yeah, so good evening, everyone, all the respected senior faculty members and young maxillofacial surgeons who have gathered in T.Y. Patil Dental College, Mumbai. As a general secretary of this association, it is my proud privilege to attend this event, which actually is the brainchild of the new EC committee, and with the hope of bringing in more maxillofacial surgeons, especially the young ones, to join in the Maharashtra state chapter. We have started this activity, and it is so good to see that the cities are having such a brilliant response from all the maxillofacial surgeons. So I am truly thankful to everybody who's gathered there in DY Patil Auditorium. And I'm grateful to Pranay Pardeshi, Aishwarya Nair, Dr. Ranganath, and everybody who has taken hard efforts to make this event. And I'm sure the upcoming lectures are going to be brainstorming for all the participants who are attending it live and those who are online. So with that, I hand over the mic to the team in DY Patil Mumbai and request them to start with the event so that everybody can be enlightened with the topic for today, that is maxillofacial trauma. Over to you. Thank you very much.
Just check now if we are audible. Yeah, Yogesh, sir, you can continue.
Yeah, so right side parasymphysis and contralateral subcondylar fracture.
Yes.
That's what we are dealing with. So both need to be treated with open reduction because it's a lateral displacement of the condyle, so it has to be treated with open reduction. And parasymphysis surely has to be treated with open reduction, right?
Correct, sir.
Yeah.
Anybody else who wants to add to it? Aslan?
As sir rightly said, I think we have to go for open reduction internal fixation.
How would you
Just
approach
to
the
elaborate on the stepwise treatment, maybe we can go with
The dentate segment first.
yeah, opening of, maybe I think first of all, I would like to open both the sides, even the condyle and the parasymphysis. Just look through the fracture sites, then we'll go for the maxillomandibular fixation, then the parasymphysis, and then the condyle. But here I think the controversial part could be management of condyle with how many plates, because there are now open versus closed, maybe a previous, I think, older version. Now we all like to open condyle. So,
So what
I think
would your
so.
approach be, Aslan?
Yeah, okay. So approach would be the retromandibular, and even the retromandibular we could go for trans masseteric anteropyrotic approach, because I think so. Wilson in 2005 he proposed this technique, but nowadays what we use normally for the subcondylar fracture, that is TIAP approach, it has a lesser chances of facial nerve injury, because if you go for this thing transparotid approach, you have low chances of facial nerve injury.
Dilip, sir, anything to add?
I just want to know how easy it would be the transmission approach to approach higher subconjunctival fracture. If it is higher,
I think so. It would be little difficult.
so then the retromandibular would be and transfer would be a better.
Retromandibular transfer is very easier for this case.
Higher fracture line is higher. It's very difficult to return. Yes.
Pertaining to this type of fracture, I was.
Yeah. It was just a
Yes. So we are talking about how many number of plates. Aslan,
I think there should be a more controversial point, as in nowadays we don't normally focus on whether open or close, but we normally now ask how many plates should be placed. So yeah, I would suggest a delta. Yeah, I would
Subcondylar, so it will be easier to put two plates, I think, and goes by the transfer. And for the chin, I guess the CLW is there, right? So
Yeah.
CLW will be the right choice if at all it is not healed and you are treating patient within 7 days. So you open it and with the rigid fixation at the parasymphysis and plate condyle with the two plate along with the sigmoid one and along with the posterior bottom.
anyone who likes to.
If it's two plates, then what should be the position of two plates? You will be able to do two plates. That is the thing, like two four-hole plates. And how feasible is it to put two four-hole plates in a fracture which is
I think it depends on how much exposure you get.
To you to plate. So if you can plate posterior border with the 4-hole with gap or 4-hole with plate and sigmoid with the 2-hole will be good enough. So if you have, of course, the bone stock has to be there to place your two plates.
One plate on the posterior border and one plate next to the sigmoid one.
I can pick up pick up plate which is 1.25 which is much more sturdier and four-hole plate as a single plate. And I found out to be a good result. I mean, I had a patient who had either a fracture of the plate or screws.
I really, no, then I think it's said is that two plates are required. And even in two plates, you've seen fracture. Honestly speaking, when we have put a plate behind and in front, they are fractured because the lateral pterygoid pool is extremely strong. So It is there. In fact, now I started using a stouter, meaning one you said stouter posterior, but augmented one. So I just wanted to talk to Archana said a very interesting thing that exposing both the fractures first and then going in for recognized. You know, the only problem which I feel normally we do that for a mid phase along with this is that one external set and one internal set is what I feel. You know,
Yes.
yeah, I mean, I don't know how you would, unless you do the external fracture first and then go in for transform. That will be a little bit of a problem, practical difficulty I see.
So which fracture would you play first? What is your sequence?
Normally dentate first.
So you have
But if there is a huge amount of vertical reduction of the ramus height, then you can even place it. I mean, the contact fracture first.
Can I just one?
Yes, sir.
See, my humble request is that whenever you do a subcondylar fracture, unilateral, bilateral, one plate, two plates of course is a must. There is no question about putting one single plate, two plates, all right. But please inject Botox in the lateral pterygoid. You see, we all of us we work so many times on this, and irrespective of however well you achieve reduction, we have seen plates fracture and we all use imported plates now. So please, the lateral pterygoid pull must not be underestimated.
Hopefully a soft diet for the longer time, sir.
Yeah.
It's very difficult to control that.
Dr. Nishi, I have a point. Because it's a subcondylar fracture, I would like to go through the approach transmesenteric enterocarotid approach. In case of neck fractures, yes, transcarotid. In my experience, subcondylar can be handled well by enterocarotid approaches too.
Okay.
So that can be one option because there is no chance of facial or injury, no salivary fistulas.
I just want to know, is still this fracture from internal and external? This, I mean, for the last 6-7 years.
For the condyle, we do. Because TMJ is something which I normally would like to, especially if you're doing a high condyle and entering into the, when we're going to put a screw in the head, definitely do so.
Yes, in the head is a different story. What is stopping off?
Yeah, that's a, like even FZ, possibly I like to put a separate plate, except when it is infraorbital, maxilla, mandible. I think I will still go in with one set. I would otherwise you prefer.
There's a lot of evidence on this topic that it doesn't make any difference. Actually speaking, and few of the patients, whatever I have seen, it actually doesn't make a difference. Because if you don't have practically a second set and you are forced to use a common set, it doesn't make as of yet.
So after 2 sets, suddenly somebody uses that.
No, not just 2 sets, you require 1 screwdriver.
I think so we should forget about the instrument. Sometimes changing drugs also becomes an issue.
We should not speak this on social media. Sorry. Wanted to say something. No? Okay. So this was an old case, transcarotid approach. Unfortunately, I could put only one plate and I had a wire in the posterior area.
What about a 3D plate, a delta plate, whereby you put one plate and you still have a 2 plate down there with a triangular like delta. So it does hold quite well.
Yeah, that makes sense because you have your plate going in different directions, putting it into different directions. Because if you put a delta plate, I don't think you have space for anything else.
Yeah, but then if you are putting one, if you are getting sufficient place on the head and then screws down there, it holds pretty well.
Because sometimes there's not enough bone stock to put 2 screws.
Yeah.
Okay. This was the patient post-op with the occlusion. A similar case, just to show that this is a much lower and easier fracture with 2 plates. And I think we discussed dentate first, followed by the condyle. This usually is a viva question because half the people still do the condyle first and then do the dentate.
Just a moment.
Yes,
Last, I just want to speak.
Is it necessary to split archbar every time? No. So this is 2013. I don't use archbars now.
No, yeah. What I'm
Why don't you use archbars? Don't use archbars?
No, split.
Here I'm talking about this X-ray.
We used to do this as PGs. So if you have, if you place your Hashbars before your reduction,
No, split.
I'm talking about then split it. Because this Hashbar is going to be useful only for your IMF. It is not holding your superior quarter anyway. So it's just split.
So what we do is, what Jayant also states that yes, I agree. I was also from Nagpur, so I know we used to split Hashbar. But then when I came to Mumbai, what we do is we keep Hashbars loose on one side.
Yeah.
Don't tighten it. When we get the occlusion, we tighten the remaining Hashbar. So what happens is, post-operatively, when we have an Hashbar, it gives better elastic traction you can give to the patient. When you split, it will be a little difficult. That's the only advantage. But I also learned to split Hashbar when I was.
If you are splitting Hashbar, then there is no use. We can use eyelets then. Then if you have
Sir, one question for you then. If you don't have an Hashbar, will you use an eyelid and treat this patient?
no.
No?
Hashbar. Achha, then I will definitely I will use eyelets.
Exactly.
Yeah.
Actually, we can use intermediate screws.
Yeah.
There are so many.
That is easier.
Okay. So
In the rules, and just to enlighten one more point, sir, we have easy Hashbar also available. Because post-operatively, to use elastics, we need Hashbar and not the eyelid screws.
When you use eyelid screw, that's the problem. This is an easier option.
elastics, if the eyelid screw moves sometime. Okay, so one more. Sorry, sir.
Contact fracture is not easy to reduce. Whatever you.
Yeah. Reduction is easy after reduction.
So assistance is very important. You cannot have regular assistance like one sister just first time assisting some subject.
Yeah, very good. Very good.
So assistance also is very important. Because surgeon assisting you is
Very much the best.
and 6 hands are
Again?
almost 6 hands are.
Yes, we will.
Hi, Nishit. Yeah. Regarding this unilateral fractures or quadrilateral fractures, in most of my case, my observation was when you do a fixation of the rendered part first, you get occlusion. That's not in cases. So many times it might be unstable business cycle in the quadrilateral lateral or medial part. I just do an IMS in such cases. And in future, after 15 years, I try with an elastic if I get it during the occlusion. It does cordial has a tendency to be in the occlusion with elastic also. But for elastic also be specific to use an heavy elastic, like you can use the elastic from the your Velcro or IV's eyelid. It's a thicker elastic. So reduction, condylar reduction, I don't think in unilateral condylar cases, I don't think you need much plating in such cases. Apart from displacement or undisplaced unilateral cases, because it's one observation.
If you have anteromedially displaced or a dislocated condyle, you still would not open it.
It's about it's about
Subcondylar.
Subcondylar fracture with a dislocation.
Open. I think there is open will be the first.
Exactly. And if you're going to, then my next question for you is, if you're going to put the patient in IMF, why plate the suffices?
The duration is less than 1 week.
So 1 week, 4 week is very
The whole idea of doing an open reduction is to prevent IMF. If you're still going to put in an IMF, it's not good. There is no point in doing an IMF of condyle and suffices and still putting in an IMF. If you are doing an, as I said, symphysis fixation and no this thing, it doesn't make sense. That's right. When you put an Hashbar, give a line for 4 weeks, it would work.
Yeah, sure.
There is enough literature now, sir, regarding the role of MRI before you decide whether you don't open the condyle or.
Patients are ready to go for removal implants unless a surgeon can something.
Only endoscopic surgeon would do that. Otherwise.
What she's saying makes sense. It is now being proven that the disc, when you have an anteromedial displacement of the condyle, it takes the disc along with it. A lot of times you will find that it is difficult to reduce the condyle back in its place because your disc is actually impeding it. But then we say, go ahead. And we go ahead.
So that is why we have kept this difficulty session after this.
Yeah.
So that we discuss what we should do and what we are not.
So the next case, we have a 36-year-old male who had a fall on the chin, a CLW evident on the chin, posterior gagging of occlusion with an anterior open bite. This is his X-ray and CT plates. Parietal condylar fracture with a comminuted symphysial area fracture. Prasad sir, would you like to comment on this case?
Yes. So, first of all, I would like to, first find out the factor in the simplicity.
We don't have, we have not put all the places, the CT, 3D CT photograph system, which is showing.
Not able to open this factor is very high level. So, opening and fixing it to be not right. Close relationship.
Yes, so, yeah, because seen by me and, as they say that the parasympathetic bilateral corneal fracture is one of the most difficult. So I took experience that while doing this, and basically when you have a comminuted parasympathesis, so to get in all those small fragments together and like that. So what we did is, yes, exactly as you said, we plated the comminuted parasympathesis with the load bearing plate, the reconstruction plate. First, we got all the small pieces of the bone with these small plates together, and the intrafragmentary reduction was done by load bearing reconstruction plate with the locking screws. And then, as you said, the corners were, the neck and the almost that looks like a capitular fracture, the left side. So we didn't open up. Now, yeah, I kept the patient on post-op elastic, and what you call as a hypomorphion. We used to do that during PG. So really this time it could help. So I built up the posterior acrylic plates, and you can just disengage the posterior ramus, and then you change the fulcrum, and then you put the anterior elastic to get the occlusion. So the occlusion was not great on table, but yes, post-op I could achieve satisfied occlusion.
But over a period of time, you go close relation in such patients.
Yes, that is what. So right now the patient is on elastic. I put the hypomorphion on the posterior to disengage the posterior ramus, to increase the posterior height, and to decrease the open light. We put on the anterior elastic. The other problem with this fracture, what we all of us encounter is the patient widening because of the fishboning effect. So that was the other reason to put the reconstruction plate, and as I've gone extraordinary, there was a big failure, so I could see the lingual fracture also. So we did the overbending of the plate and could reduce the fracture and put the proper consultation with the burden.
So one mistake, when you are fixing the synthesis is like you get it you do the angles, and then you see a nice the fracture is not there, and then you do the plate. But later on you see that the occlusion is lost. So what normally you do is press the angle.
Yes, Ellie's maneuver that also we did, and all of these help, and we've achieved a good like satisfied occlusion. Yes.
This is like not exactly a typical batsman, but since there is a symphysis and bilateral condyle, I think at least one condyle should be addressed.
Sir, I have one more question here. I have one more question, just to interrupt you. If you look at the OPG, it looks as if it's a neck fracture. The moment you go to your scan, maybe we need more cuts because I don't know.
Right.
Wanted to say something.
Yeah, that's exactly why I said the OPG sometimes is very deceptive.
Yeah.
Such fractures, you decide on the OPG to open and realize that it's extremely high.
Yeah.
You open up a retromandibular and then say, no, you should have gone a pre-auricular.
Yeah.
So, it is never decide a condyle on OPG. You must get a cut. This is definitely a high condyle fracture on both the sides.
Yes.
You can argue, you can open, but
How do you manage?
if you want to open, which we have done, we possibly just put one screw to the cerebral fracture, the body fracture on the left, on one side, and the other possibly we can leave it. But otherwise, reconstruction plate for the anterior, give elastic traction and set the occlusion. Make sure the patient doesn't go into any kind of ankylosing. Follow the patient up, short IMF, and give traction.
One decided symphysis mandatory.
Yes.
One deciding factor which we can also take into notice is after we have done the symphysis on table, if we get the occlusion, then we can manage the condyles with close reduction. But if we don't get the occlusion, that means there is some obstruction at the condylar end. So then you need to open it and get it in.
There is
Hello, just a question. As Dr. Yogesh said, we will open one. So which one would we go for?
As we said, the left side we will open with a pre-auricular incision and give a sagittal screw, long screw.
Anybody else who wants to add?
But it is very difficult. You have a head fracture, put it immediately by the lateral. Put it in position and place it. Put it, hold it, pass a screw, and still you will not have a fixation.
Just out of curiosity, if anyone has observed this type of fracture in 3 days and such a high condyle, has any observed resorption in this proximal segment?
Yeah.
So better to go for a close reduction for condyle.
In such high cases, yes. Hello. Yes, sir.
I've been taking condyle fractures for a long time. And the basic thing is, it is the patient who has to help you to do what you want to do. They don't want to do it. They don't want to do it. They don't follow to your advice, especially when you put elastics or at all you are putting into it. They want the mouth to be open and they want to eat. So I always feel that in any situation, there are only two people involved. One is the patient and second is me. They don't listen to anybody. And then they come up with a complication. And then they say, you did something and that's why the complication has taken place. Now, I would say that in this particular case, if you remove, both the condyles have to be removed. But both the condyles are medially placed. And if you are going on the medial side, it is very difficult to go on the medial side. We used to take out the condyle completely at the junction and then put a wire inside the upper and lower and then put in the position. But even then that doesn't give a problem. Earlier times taking out the condyle or doing the condylar surgery was not allowed at all. I know that. Dr. Jidwala never used to remove the condyles. But removing condyle was a big job. Apart from the fact that the facial nerve might get damaged, it may not get damaged, but it might get damaged. But the point is that the patients are not going to cooperate with you. This is what I mean. So you have to if you are better said, you have to tell the patient that you might have to undergo second surgery. Second surgery is to be done and try to help at that time to get the occlusion. If the occlusion is given and then start, put elastics. Put elastics means put the Eris Akbar and put elastics and give exercise to the patient. If the patient goes for exercise, and that exercise should start within 1 week. Within 1 week before the callus has formed. And if the manipulation is done, what I do sometimes, you will not agree with me, I put the patient under GA and I manipulate the mandible in such a way that the condyle goes into the fossa. And it remains there. And even if it has not gone, the way you should go anatomically, it is very close, two fractured areas together. And then ultimately it settles, but there is a distinct possibility of going for ankylosis, which you have to tell them. And you have to tell them that if you come next time and you can't open your mouth, I have to remove your jaw. Something you have to scare him. You have to do that. Otherwise, it doesn't work out. This is what I found.
Thank you, sir. So we go to the next case. So we have this 40-year-old man who was brought to Diva Patil Hospital by onlookers with a history of RTO and riding his bike. There was a stone from the construction truck which fell onto his face. No history of loss of consciousness, he had bleed or vomiting, seizures. So no head injury component. So this is the patient who's showing a big, huge swelling on his left side with a CLW sutured there, occlusal derangement, and this is his CT picture that we have. So Dr. Dilip, you would like to speak on this case?
Okay.
How would you manage this?
This is severely communicated, let's say, famous fracture antibody. So I would prefer to put a load bearing reconstruction plate along with maybe the smaller fragment. We use a intraosseous wire to just stabilize it there. But the whole thing would be a reconstruction plate starting from the parasympathetic region going up to the condyle. That would be holding it in place, and rest all is just kind of holding on to that plate until it heals. So this would be my method.
Yeah. So this. Would anybody of you think about doing a primary bone graft if there is a big loss?
Yeah, obviously. Defect is big. So you're looking to
once you debride it, so
yeah, the debridement I would do an aggressive debridement unless if it is grossly infected or there is a lot of dirt in it or something like that.
It's a compound wound.
It's a compound wound, but if there is no dirt when you examine it, then I wouldn't do an aggressive because a lot of those things will be remaining as a bone graft itself, like since you have stabilized it with a recombinant plate, the rest of it will act like a bone graft, like But yes, if you have dirt, if you have everything, and maybe then you may remove some of it, but hardly you would use until this is a gunshot wound where you had a loss of bone. Not at least I wouldn't put in a bone graft because that itself will act like a bone graft.
And I don't think primary bone grafting is any kind of good in this initial this because if you have a compound wound which is already dirty and you're going to clean up and be unsure whether you have made it clean enough, then a bone graft is going to do worse than what the native bone would have done. You could keep the native bone itself as it is. Yeah.
What's that?
Regarding this primary bone grafting, muscular or vascular, right? The option. In this case, we have soft tissue there.
Yes.
So what sir said, we don't need a grafting in such case. If there was a soft tissue loss in this case, then we are not able to close it. Because it's a compound fracture along with the soft tissue loss may or may not be. But since it is soft tissue is there, no need of any primary grafting in such cases. If there was a soft tissue loss along with the compound fracture, there is always chance of exposure plate, reconstruction plate, and you need a second surgery of three fibula or any other graft. So you should take focus on the soft tissue also in such cases.
Correct.
Yeah. We did take issue of the cognizance of the soft tissue. But what we did was, as rightly mentioned by Dr. Dilip, we used the load bearing plate from the parasymphysis till the subcondylar region. One plate was used. The whole segment was first stabilized, and then the smaller fragments, whichever we felt could hold onto screws, they were used, and screws were placed. And of course, you can see for soft tissue management, we have used rail. You can see that, so that there is no collection of edema post-operatively, and there's no chances of avascular necrosis of the small bony pieces. Also, the localized wound which we had, we managed it with PRF dressings on the outside, on the face. The wound which we had, we managed it with PRF dressings. So, and this was a freak accident. If I talk about this accident, the patient was standing with his bike at a signal, passing truck from behind. It just passed him at a fast, and there was a boulder which fell off the truck and hit him on the face. So you can compare it to a high velocity injury. It can become because he was standing and a large boulder fell on his face. He had a helmet. The helmet was crushed. We have seen it. The helmet was crushed to that extent. the injury was there. But yeah, of course, we need to put arthros first, get the teeth in occlusion, and then we have to move around the remaining part of the radius.
This kind of injury can also be seen if there is a gunshot injury. In a gunshot injury, yes, there is a role of primary bone graft and probably getting some.
Dr. Nishit, I would like to appreciate one thing in this case, that all the small fragments have been kept together by AO principle with small plates. And then the reconstruction plate. I don't recollect whether there was any inferior alveolar nerve injury in this, Dr. Yogesh? Any paresthesia or something? Was it there?
He had paresthesia, of course, he had paresthesia, but I think it is recovering.
It is recovered. Very nice.
Okay, we will move on to the next. Yeah. Okay, so this is just his post-op photo. So we have a 27-year-old male with an RTA. He got stuck between two buses. Right. We will go. This is his clinical photo. We can see a good amount of midface disruption. This is the scan finding. Okay. Dr. Aslam, would you like to speak on this? I'll go back. Want to see the scan again?
Yes.
Yeah.
So I would like to go with the approach from the mandible start and then outside in. Maybe the mobile segment and then the mobile segment. So starting with the frontozygomatic suture. Frontozygomatic fracture. Then with the
how would you approach the frontozygomatic?
Approach bicoronal approach.
Okay.
And going with the outside and maybe frontozygomatic, then the intraorbital or bilateral, putting the patient under IMF obviously, and then going to the condyle.
Okay.
Is bicoronal approach really required in this?
Left side, if you can observe, I think so. NOE fracture is also there. So
there is an NOE component as well. There is an NOE scush.
So it is very difficult to work.
But the left side is undisplaced fractures. Because it's a 3D, it is not showing well. Okay, Hirkan wants to say something. Okay,
bottom to up. So you first fix the maxillomandibular complex first. Make your mandible stable by fixing the condyle, by fixing the any other.
This is for the fracture in the mandible.
Yes. So first put your abdomen, put your maxillomandibular stable base of the mandible, and then go from calvin from the bottom top to down and from outside in. So yes, of course we exert intraorbital
condyle first and then the midface.
Right.
Okay. Dr. Rajesh, your comments?
Yeah, I think bicoronal approach only one of the just open exit on the right side.
Okay.
The approach is perfect.
Okay.
Both sides. I will intraoral maxilla. The condyle can be addressed.
So she wants to go for the condyle first, followed by the midface. Will you follow the same sequence, or will you follow the midface followed by? Okay. Dr. Dilip, since you've treated this case, you can speak.
This patient had, as you can see, this patient had bilateral subcondylar. One was displaced and another was undisplaced. So he had a severe right-sided zygomatic arch as well as the zygomatic maxillary complex, extracorporeal fractures, bilateral, and like so we approached as a submetal approach for an integration with this. And we preferred a bicoronal because of the zygomatic arch, which was communicated and crushed in that. And also, since we wanted to fix an NOE fractures and bilateral exit fractures. So it would have been easier to do instead of having multiple incisions. Right? We would have had a preauricular exit, bilateral exit. So in this case, I mean, it's easier to say that we will do this top to bottom, bottom to top, and all that. But I would, I mean, that is my principle right from KM days. We were like, so make a plan like before you go, once you see the fractures. So right from the intubation, what would be the next step that goes on? So after exposure, I mean, I would personally like make an exposure of everything, like do a biclonal subciliary if it's required. In this case, maybe just subciliary, but otherwise generally subciliary. Then maxillary vestibular approach, expose the condyle, expose everything. Then what I would suggest is basically, since occlusion is one of the main factors that you need to get. No matter what it is, at the end of it, if you don't get an occlusion, you wouldn't be the patient, neither the patient nor you would be happy, because the primary goal of achieving a function is not achieved. So once you expose everything, put in growing disinfectant process, mobilize the maxilla, reduce the condyle, put an arch bar. I mean, all my fun patients, arch bar is a must. Even if it is a split arch bar, in this case, sometimes you will not be able to put an arch bar like continuous arch bar. Put a split arch bar in such cases, reduce everything, give an iron. Okay? Reduce the condyle, plate the mandible first. So mandible is my major thing, because especially if the NOE is communicated, you don't have a stable upper face base where you can actually go in and start fixing it. So fix the mandible first, where if there's a symphysis, luckily there's no symphysis in this. Even though there was bilateral subcondylar, I prefer to fix only one side because the other side is undisplaced, or it was just a kind of a thing. So once you fix the condyle with an eyelet, then you have a stable lower facial height, which with projection as well as anteposterior as well as a vertical projection. And then I will fix the FZ NOE. That would be correcting the lateral width as well as the upper facial height. And if required, in this case we didn't do it because you see we were not planning to do this because the CT showed that there was a toe fracture, but there's no herniation, nothing. So we thought we'll avoid that. Then we went ahead inside the respiratory and fixed the zygomatic process and the zygomatic arch completely, everything. And this was the final thing. So we gave a post-op IMF, brief IMF for 2 weeks, and this is what we said. Yeah.
Yeah, exactly. I said, if you're going to fix the NOE along with the exit, bicondylar is the way to go. I don't think the patient will understand. That's what we had a type 1 Markowitz NOE fracture.
Last case for the 33-year-old male with a history of injury to the left eye while playing cricket. No loss of consciousness, vomiting seizures. Yes. Yes. What I would like to know is where bicondylar was used with a great result that you get. But wouldn't a local separating angle with a lateral cathotomy also work? How would you fix the NOE?
NOE?
Sir, I would just extend it transcurrently, and because it's a Markowitz type 1, I could achieve it with the fixation of the.
Superiorly to achieve it, even if it a transconjunctival, superior to fix the slope because very difficult.
Transconjunctival needle going higher sometimes. You are slightly worried about, you were a lot of things. You wouldn't want really to do that. I would prefer an external incision, a small external incision.
Even like Visu is a local approach with external edge or a gullwing, followed with a subconjunctival with a lateral cathotomy.
As you said, you would have used multiple incisions. So my aim, especially for this case, was I need to fix the zygomatic arch. It was like communicated. I mean, there was, because of the arch, the base was, until unless you fix the arch, so I need to fix the arch, FZ, NOE, bilateral. So I have not taken subciliary. I have left the infraorbital margins and it is here in so I have not taken subciliary at all in this case. Otherwise, I would have taken a subciliary. If I had taken a subciliary, as I said, extra data and probably manage with that. In this case, I have not taken subciliary. It is just a bicondylar, fixed all the top, and it already fixed it, and the condyle was attached with submandibular and retromandibular.
Yeah, I agree with him. If it's a combinated arch, then you have to use a bicondylar.
Yes. So we will move on to the next because this is the last case. Then we can discuss over topics. Okay. So this is a patient with a history, very typical history while playing cricket. He's hit on the face with a ball. Complains of minimal blurring in binocular vision on the left side upper gaze. On examination, intra-white light ecchymosis on the left side, subconjunctival hemorrhage where the posterior extent is seen. CT scan shows a fracture of the orbit reported as entrapment of inferior rectus muscle by the radiologist. Although clinically the patient had good motility of the eyeball, it was mentioned on paper by the radiologist that there is a entrapment of inferior rectus muscle. So how would you proceed with this case?
So, like this was a zygomatic complex.
This was a pure broad fracture of the
There is no zygomatic.
only orbital floor. No, pure broad fracture of the orbital floor.
And pre-operatively there is no entrapment.
Pre-operatively, as in post-trauma?
By
Post-trauma, there is a radiologically reported entrapment of the inferior rectus muscle.
No, post-suction test.
Post-suction, no.
No. I would prefer to do a post-suction test pre-operatively, confirm that there is no entrapment, and then treat it conservatively.
Okay.
What he says is right. I think post-suction test is the most important thing you would want to do. Even if they say reported CT as like an entrapment, because they just report any ablation, they will report it as an entrapment. Most of the time they will say it is an ablation.
This is an ablation. Which is very specifically mentioned by the radiologist.
But what if a post-suction test, if it's not there, then you can observe it for some time for diplopia, especially for diplopia.
Absolutely.
Forget the post-suction because here he is able to move his eyeball. He was able to move his eyeball.
And no diplopia on upper gauge?
Minimal diplopia. Minimal could be from an edema as well.
Yes.
But then the next question is medical legality. Say after 10 days, our patients are known to disappear after you say nothing disappeared. The patient comes back late and tells you that there is diplopia now, because now somebody is going to read the CT scan report and say you had an inferior rectus entrapment because of surgical indication. Any medical legal?
Medical legal knife is two-edged. Even if you do something and you end up with a complication, it's a two-edged.
See, we always teach our residents, that's why don't read the radiologist report.
Absolutely.
Make your own report. Read the scan yourself. Radiologists, generally, we are better at reading scans many a time than what actually radiologists are. No offense to them. So
you're going to just record the diplopia or do a post-suction test. So you have that on file. So I don't think medical legally it should be an issue.
On OT table, did you do post?
Sagar.
You on the line of most of the radiologists write a sentence in their
Exactly.
So as long as you are recording the evidence and doing a proper clinical examination, proper post-suction,
And even if it comes after 1 month with diplopia, in these cases, you could always release it. They is still available for a secondary diagnosis.
Yes, absolutely.
Did you operate this patient?
Yeah.
Did you do the post-suction test on the OT table?
On the OT table, yes.
So it was.
But on the OT table, once you taken on the table.
But still, what was the finding? Because you went ahead with your.
As I said, forget the post-suction, the patient is able to rotate his eyeball up.
Not indicated.
So I don't need to go and hold his inferior rectus to pull it up.
When we do the place, we should just do sinus packing. That would support the blood.
Even sometimes later also in the muscle fibros, you might see the diplopia after a week or so.
Yes. So there is an ablation. I don't know how significant this is maybe. That is your take on this.
I would see if there is no diplopia. I would
say minimal
diplopia.
Minimal diplopia. The patient says there is a minimal diplopia when he turns not, but clinically I could see that his eyeball is moving.
I would keep the patient observe and see if required to do a secondary operation. If at all. And mostly you won't need.
Okay. Fine. So, anyways, there was a big defect which we closed with a we put a reformed titanium mesh. That's the synthesis mesh. Now this side is moving more. Okay. So, any closing comments? With endoscopic. No, endoscopic. Just get where? You have to open surgery. So it's not. And this was today into a
Transcranial divert.
You know, this is stopping.
No, I don't think sinus packing there yet. It's better.
So there are those photographs straight to movie scan.
Yeah, I don't.
How many of you will really do it in practice? Yeah.
Can I make one?
Yes, sir.
No, honestly, the first case which you showed in a 17, 18-year-old girl with undisplaced fractures. Yeah. How many of us, if you like, my boss used to say, Dr. Dhulani, if this was your father, mother, brother, or sister, would you do an open reduction? Yes. Please, think on your own self and decide. You could just watch this patient with intramascular fixation for 2-3 weeks, and in case of an infection or something, consider opening. This is my feel. I leave it to you.
I have one question.
I agree with you, sir.
One second.
It's a case of close reduction.
So in this case, there was no interfragmentary mobility significantly, right? There was no interfragmentary. So would you consider not doing anything and putting the patient on a liquid diet?
Absolutely, you can do that also.
Yes. Do at least see, there is another simpler method I have found in last so many years. If you are an orthodontist friend, we can put a few brackets on either side and do intermaxillary elastics. That also works. There is no need to put elastic.
My question is whether you just leave her on a liquid diet?
No, I won't. I will use elastics. There has to be some restraint. There has to be some restriction of opening of mouth.
So actually I have seen this patient. So what we put elastics to the patient for the patient, and the patient was not ready for the elastics for another 4 weeks.
You don't require 4 weeks for this.
Every 3 years, you prepare 3 weeks.
Not in 3, 1 or 10 days is fine.
She opted for the surgery rather than the conservative.
Very rare happening. Most patients refuse surgery. You are in a different situation.
You convince well.
Thank you, Nishit. Well done.
Just to add one point. We've been hearing the wheelchair since my whole television days, and the wheelchair used to say this thing whenever patient comes, whether he's your brother or sister. Yes. So after that day only we started doing this, and believe me, I think so. We try to do conservatively as much as possible.
That's my teacher's thing.
Even 20-25 years down the line, we will also say that our teacher. Yes.
I hope all this is a divine.
DY party organizing to invite me. Thank you, Mukul sir. As a young maxillofacial surgeon, now I won't look young, but.
Mahesh got
Actually,
it.
this week I trust. Oh, okay.
You have to go on. Come on. Thank all the patients.
Thank you so much, sir. I will now request the chairpersons to felicitate our panelists and our moderator. First, catchy moderator. Yeah. You will.
Come on, fast. Fast.
Dr. Nishit, Dr. Nishit Agni. Hands come little ahead, the reflection is coming on face. Yes.
Well done.
Dr. GSV Prasad. Dr. Usha Asnani. Dr. Rajesh Sabnis. Dr. Gule,
That is why I asked you.
Dr. Nikani, Dr. Arslan. I invite Dr. Charu Birotra and Dr. Raghunath to come on the stage to felicitate Dr. Archana Dusia and Dr. Jayanka. Thank you so much, everyone.
Are you ready? This has to be the most happening time, na?
Now let's begin with the most awaited section of the day. Challenges faced in clinical practice by oral and maxillofacial surgeons. To chair this session, we invite Dr. A.P. Chittre sir and Dr. Harjit Singh Kalsi sir. Dr. A.P. Chittre sir has completed his BDS and MDS from Naya Hospital and Dental College under the great Dr. MSC AOMSI. He was formerly honorary maxillofacial surgeon to His Excellency Governor of Maharashtra. He has been awarded the International Association of Oral and Maxillofacial Surgeons Award in 2007. He was the president of AOMSI in 1981 to 1982 and has been the head of various colleges like Naya Hospital and Dental College, College of Dental Surgery, Manipal, and Kelly Institute of Dental Sciences, Delhi. He has received the Global Outreach Gold Medal 2022 for top 100 doctors in dentistry. Dr. Harjit Singh Kalsi sir, he is a professor and HOD at Bharati Vidyapit Dental College and Hospital. He is consultant OMFS and implantologist at multiple hospitals like Reliance Hospital, Navi Mumbai, and LH Hiranandani Hospital, Kaveri. This session will be moderated by Dr. Mukul Patel sir. As we all know, he is currently the Dean of Faculty at Bhavati School of Dentistry. He was the President of AOMSI Maharashtra State Chapter in 2017 to 2018.
Thank you. Everyone because I know post 8 p.m. Time to go for the banquet. So I'm an esteemed panelist today for this extremely interesting session. Dr. Ashwin Kabir require no introduction. Most of them don't require any introduction. Dalina madam, please come. Dr. Parker sir. Mr. Parker sir.
I think they've gone up.
Dr. Viraj Parker. He's professor at Bharati Vidyapit. Dr. Rutuja Shivai. Now the younger brigade. Rutuja Shivai is consultant maxillofacial surgeon. Returned from Middle East. So he has a lot of challenges after coming back. Dr. Sandeep Joshi. Please come, Doctor. Dr. Rishi Kosa. Dr. Hemant is not come. I welcome all of you and
Ashok sir.
So I think the organizing committee has very strictly told me that we are running out of time and we have Nishida written into our time trauma. Traumatically, we have about 30 minutes is what I've told, and I think challenges are much more than what we can discuss in 30 minutes. So this entire session is actually because a lot of talk was when the study club was formed as to young maxillofacial surgeons encounter a lot of problems. So this is actually a session open to all. So anyone can just raise a hand or whatever you feel are the challenges you face in today's day-to-day practice. So let's start from first as far as profession goes. I think when we pass out maxillofacial surgery, we realize that we know much less than what we should know. And how do you go about establishing one as a maxillofacial surgeon? We think we have several established surgeons up on with this, and I will request one of them to answer the question. Parker sir, or coming to mind, how do you prove yourself in front of the medical profession as the amount of work we do in maxillofacial surgery, and or possibly get a hospital attachment, or to do the trauma which we do so well, and to fight against medical fraternity? I'm sure young maxillofacial surgeons have this problem in most hospitals across Mumbai, where we are possibly fighting against all medical specialties, and they write a call to the dental surgeon, so and so please see this trauma. So yes, Darren madam would like to enlighten us. Okay, how do you go about my patient? Did you face this thing in your younger days, or it is what we are facing now?
One thing, you must be equipped with a good knowledge of the subject. That is important to prove yourself. And trauma is the one thing which nobody can take now. Because orthopedic people treat all the burn except waste. Nowadays, sometimes plastic surgeons who come and try to treat fracture, but still they don't have much concept of occlusion. So trauma you don't need at all. To get to the any attachment, I think it's a nowadays difficult. Try to do your own practice, develop your as much with your own friend circle, try to go as a consultant. It's very difficult to.
Sir, would you like to add?
Attachment at this time.
Ashwin Ravi sir, would you like to add? How to establish yourself?
Try and do some fellowships and all, so that you intimate your acquaintance with the elder people, and then you can go and observe them. Sometimes you may not do some just observership without getting any money. You learn a lot. You can go to plastic surgeons, other surgeons, and of course medical surgeons also. You do learn from everywhere.
So yes, getting knowledge.
Getting knowledge is very important, and then slowly somebody finds you are really good at that. They will pick you up.
It's cyclical, madam. You don't get a chance to prove you're good, so you're not good. Yeah. So again, it goes on and on and on. It remains in the same pattern. Sir, how do you establish yourself in front of other specialties? 30 seconds. You have done it for so many, 50 plus years when you're competing with a lot of other branches.
Yeah, I think it's a big task. It's not easy, but you need a lot of patience, perseverance, and tolerance. Because people, they don't believe that you're good, so it takes some time. But you continue working, show your drive good.
Sometimes I no, really, sir. Yes, this one is go to ENT. I think I can get a patient from ENT ward.
I request panelists to keep it very short, so that we have extremely short of time, a lot of things to discuss.
We must have the material. Just contribute to the recommendation.
What helps you, sir?
Recommendation.
Okay. Yeah.
So that you get only on the basis of your knowledge, experience,
right? Your
contacts with your colleagues on the side.
Right. Okay.
I feel, I feel that most oral surgeons nowadays, after they finish their graduation, first of all line up to do fellowships.
Yeah.
Everybody wants to do cleft and orthodontic and stuff. So I feel that side by side, it's very important to form a group. I feel it's better that you stick to your fellow oral surgeons and form a group, attend to cases together, and don't forget your basics. I feel do your infections, do your maxillofacial trauma, do all these things. You don't need to jump to certain scales which are, they're far away, they're far-fetched. But do continue. But don't forget to do your basics.
As a young maxillofacial, what are the challenges? Did you face such a challenge?
I'd first like to thank everyone, especially the organizing committee, to give us an opportunity on this podium with the esteemed panelists and my respectable teachers. So first thing I'd like to say is when I had passed out, I remember Mukul sir had told me, he was my guide. He had told me, see yourself from now where you'll be after 10 years. Keep that goal in mind and then start working towards it. what most of the oral surgeons who are freshly passed postgraduates, they tend to get into consulting, visiting practice. Of course, that is one grind which everybody has to go through. But one important point I would like to tell everyone is consulting and visiting practice. Always remember one thing, that at the end of the day, the patient will not know your name. Patient will never recognize you as an oral surgeon. So, like sir had told me, see yourself from where 10 years you will be there. So always remember that you have to create a niche for yourself. So don't aim at consulting and visiting practice for a long time and try and come out of it. Yes, I would like to add something.
Like you said, in the beginning, the struggle, the word, it basically starts from within actually. When you complete your MBBS. The excitement of the result goes away maybe within a day or two's time. The actual struggle you realize. So I think once you deal with your internal struggle, the next part would be having a good collaborative relationship with your associates, in the form of general networks or maybe your associate. Maxillofacial associates we are already working with or you plan to work with. And that definitely gives you a guidance for the future. And you can initially 5 years of your initial career to shape your future for the next 15 years.
So I think the bottom line is have patience, work towards a particular goal which you see yourself in the future, and work accordingly. If you have some senior who has expertise in that particular thing, there is a very good article which talks of areas of competence, area of expertise, and area of familiarity. And see, we are today blessed that we have several super specialists to and deal with. We can go into TMJ, we can go into implants, so many leading implantologists are oral surgeons, so they have devoted themselves to implantology itself. So try and gain that particular knowledge in the first 3, 4 years or 5 years after passing out in a particular super specialization, and then possibly that will help you get this. Second thing is one common thing I think some of Rituraj mentioned about is visiting practice. I think that's a very common thing. Is everyone talks about you go to a dentist will if you take some money out of whatever you earn. The name you are doing is for the dentist rather than you developing the name. Today, most dentists have 2 and 3 oral surgeons in there. This one is not available, the next is called, the third is called, etc. etc. So how do you? One is visiting practice an absolutely necessary evil which you have to do to actually gain. And second is, if you are doing, which most of us in this room I'm sure are doing, how do you protect yourself and how do you try and establish your name in spite of doing visiting practice? Because today, to start an oral surgical practice and get reference from dentists is extremely difficult. Because each dentist possibly has number of patients, number of oral surgeons are there who can come running at the one phone call and do possibly. So yes, anyone in the audience would like to talk on this or has similar experience? Or so do you all really feel visiting is a necessary evil, or we can avoid? Yeah, Shiva, you can talk. Yes, give us a mic. So we have someone who disagrees. Yes. Right. Okay.
I would not say that I am not supposed to practice minor. Because minor is something that will fetch you to, I have to say, continuity in your work. Because not now, every now and then we are not
getting a good number of major cases. So I think minor is something that we should be practicing, but visiting is something that will restrict you. As sir said, name is something that is restricted because of that. So I personally feel establishing a practice as a maxillofacial surgeon should be the first priority.
Yeah, Shivani, but what you rightly said, maxillofacial major surgery work doesn't come so soon. And let's be honest, the maximum money everyone earns in dental surgery, and which is the easier part, it doesn't cost much, it's much easier to do that. Actually, my personal opinion, maxillofacial surgery gives more thrill than money, and dental surgery gives less thrill, more money. This is what I feel personally. If you want to add something?
I mean, why is it such a bad thing to have visiting practice? I mean, unless you have a dentist recognizing you and he tells the patient that I'm calling a surgeon to do it, The patient recognizes it. You may not have, some clinics do put up the name of yours and the outside their clinic. And it's not at all like, you mean like the credit is taken by the dentist. The patient does ask like, are you the surgeon? So that itself is a recognition. And we being in multi-dental specialty, getting a referral practice in these for a standalone oral surgical practice is going to be very, very difficult. And unless you are a very established surgeon, it's going to take time. And I'm sure that visiting practice is not at all that, yes, some clinics you may not want to visit, but you will go. Like that's a different story. That's a complete different story because you don't want to do surgery in that clinic, but you're compelled to do it.
Okay, so that's one quick word. Yeah.
I would like to add, visiting practice is not just restricted to doing the third molar or the minor oral surgery. These are the same dentists who will refer you trauma cases.
Yes, exactly. So how many in this room do visiting practice? Just let's say so. Yeah, so let's assume that. So now I go to my next look. I think that is
I'm sure we'll be really, really happy if everybody does not do.
You can't eat your name. You can't eat your name.
No, so I want to know that if you are doing visiting practice, how do you ensure that you develop a niche for yourself, carve a name for this is especially for the younger guys who are doing visiting practice. How do you carve your name and how do you keep yourself medically, legally safe? Is anyone on the panel, anyone would like to?
The best way first would be to have a very good indemnity insurance for yourself.
Yes.
Yeah.
See, our medical colleagues also don't know what we do. So if you have a local IMA branch, try to get in there and give some lecture. What Maxillofacial does, present the cases, some people exhibit them. Unless you exhibit, people won't know. My husband being medical, I do attend their picnic. So there I try to call and show them my cases. See, automatically, would you do this, you do that, and that's how you can at least impress on them what we can do and then start preparing cases. Go to nursing home and other general surgeons.
Yes, so one indemnity is one important thing. Anything else? Consent. I think that yes.
So of course, consent and all those things. One most important thing, what I feel from my visiting practice, have the courage to refuse the case after visiting the clinic. You travel for 2 hours, patient, the referring doctor says, "Arey, third molar nikalne ka hai." It is a horizontal third molar. You cannot see the apices. The nerve is not seen. Blah, blah, everything. Tell the referring doctor on the face, OPG nahi hai, CBCT nahi hai. Let us not do the case. Okay, you don't want to discuss it in front of the patient. Go somewhere else. Tell him. But you should have the courage to refuse the patient. Don't think you have put in 2 hours of traveling. Kuch to karte hain. Because if you don't have the courage, then you should have an indemnity. Strong indemnity.
Anyways, you must have courage or no courage. Second, one more thing, very important point. I agree. Second is, like Shimari rightly said, you should have your own practice also. You can also have, which many of us still do, if you have a particular case which you can't manage in someone else's clinic. All of us know visiting practice is extremely difficult. The suction doesn't work, the damn motor doesn't work, the assistant is pathetic, everything. So if you have a difficult case, be courageous to tell the particular referring doctor, please send this patient to my clinic, I'll be able to handle it better. Trust me, if you have doctors who want their patients to be with them for a longer period of time, they'll take your opinion on this and possibly send you a particular patient, which is very difficult. And that's how your practice slowly goes. Yes. Yes.
Ask how to carve a neck if you are doing just your visiting practice. So if you are persistent and if you are doing good work, it will take time, but people will recognize you. And secondly, it's not that your name doesn't come up. If you are persistently visiting, even the patient asks you what is your name, and patient tells you that I want to visit you only next time if he or she is satisfied with your job.
Yes.
And this business which you are telling that people call up second, third number. So in the bargain they realize who is better, and with time, sir, that question
as we grow the number of people is increasing. Yes, Asher.
Sir, about what you spoke, that if you tell them and you make them understand, they send the patient to you, to your clinic. I think that is very difficult. There are very few people. I have two dental clinics on the same floor which I have a clinic. Even they want me to come and see their patient in their clinic. They do not send across on the same floor. They say, no, we want everything done in our
That's perfectly fine, but if you go for 10 cases, if you tell them all 10 you said, yes, they also feel insecure, etc., etc. If you go for 10 cases and tell them 11 cases is very difficult, then yes, that is how I'm just saying these are attempts to improve your own practice. So have a strong, good consent form on your own name and not the dentist name. Please keep the consent form with yourself. As someone rightly mentioned, please do not be definite to refuse a particular case if you feel that particular case need not be done at that particular time. Yes, you possibly waste your time, waste a little bit of money, but don't land up in a having a poorer name than a better name, and have a strong name. These are three things. One little thing of the same visiting is these are all pointers which young maxillofacial have said me, and these are not my challenges. If people talk about charges, there's a lot of disparity in charges, and they feel that dental colleagues doing specialty practice in other branches like orthodontics are able to have some kind of minimum norm which is not followed in oral surgical practice. And we have oral surgeons going for, irrespective of how the tooth is, advertising and charge only this or that. So is there any particular, do you all face this problem, or this is an isolated problem? Yes.
Very common problem.
So I guess with regards to the charges, we need to be together. We need to be collective. We need to decide as an association what is the basic we will charge. Yeah, a quorum like this would definitely.
Actually, I always feel that somehow visiting practice and oral surgery in a dental clinic, just because we take less time for it, is normally always undervalued. Because so they always undervalue because they feel that if we actually project that a wisdom molar in a patient who is active, who the patient has a tongue moving, a deep seated, big bulky cheeks, can be really an extremely difficult proposition. It doesn't mean just we take a less period of time. So this thing, I feel all as maxillofacial surgeons must try and talk to dental surgeons who send us. Even if the damn third molar is simple, you must always say that it is difficult. Oh, wow, so, because that's how you possibly put up your, orthodontists never taught that skill to anyone for all these years. We did CDS, we were not nothing on ortho. Habits was taught to us for the 4 years of orthodontic training. So oral surgeons, possibly everyone does third molars. The seniors, we go to senior practitioners, they're doing more third molars than what we have done. So we must be able to, I won't say sell our skills, but actually project our skills at it being a difficult particular surgery. It's wrong of us to say that I'm going to come and get it out and go on. So that's one way of thinking here. Association, yes. I don't think we can make any, vice president is here, whether we can really make any kind of comment this that we should charge. So I really don't feel, because area of practice is different, expertise is different. But my only suggestion is, as you get senior, please charge a little better, so the younger oral surgeons can charge. If you have seniors charging very less, it becomes extremely difficult for the younger client to develop their name and their particulars. Yes,
I would like to add on, has anyone experienced that you have removed the tooth in 5 minutes and quoted some 5,000 and then just say that the 5 minutes mein nikal gaya? So you have the charges.
And there are times when the dentist says, please take more time.
Yes.
Just
keep the limit in the
There have been occasions. I would like to specify one occasion that I had, where the tooth came out and the dentist tells me that, okay, you can keep drilling. Okay, go on, okay, go on. I've charged him 10,000, please keep on drilling.
Yeah, she has a consultant, and he's been there for the last 12 plus years, 11 years, and I'm sure he must be having some stories to tell.
I have some recent stories actually. So I did see, the bigger the tumor, the more non-affording the patient. Patient had come with a mandibular aminoblastoma, and as usual I got a call from the social worker of the hospital. Sir, देखो ना कुछ कीजिए. Spent 2.5 to 3 hours getting the tumor out. I put a minor category. The plastic surgeon took a supra major B plus category. The patient gave me blessings left, never bothered to follow up. I was wondering where is the patient gone, but the patient was regularly following up with a plastic surgeon. Because the patient had the impression that I have done some minor work.
Call GST Prasad the next time.
You'll have minor, you'll have super major. If you're charging less to the patient, you're not trying to get it in your own work, and it's not, you're not questioning yourself.
Yeah.
You're undermining your work.
Okay, so that's an important point. Even if you're doing a simple extraction.
Preoperatively, must see the patient, talk with him. I'm very often.
Okay, one more challenge which I feel this is what is the preoperative investigation you do for a third person in your visiting practice? Do you do anything? How many don't do anything? Just go ask the patient history and get out the tooth. Oh, all of them do some test? What test? Like what? Next test, what test? So every third one who does it undergoes the CBC. Depends on the person.
CBC or random sugar, BDCT, PKI. Basically, most of the symptoms.
Anyone else would like to add or subtract from this? You do CBC, BDCT, PT, INR, and random
sugar if he is not diabetic. If he is diabetic, then
yes. Anyone else?
What about the triple H?
So you do triple H also?
No, I don't.
Dennis is not your yes, all do this test. I'm sure you are not trying to put up a hand and say you don't do any test. No one, please.
Yeah, sir. I don't think we can do this. Honestly, we are losing the consult that we're getting. So very honestly, I mean, for patients who I feel, I mean, I ask for a I ask for a verbal history at that point. If we say they're hypertensive, I check the blood pressure at that time. In my clinic, I have a glucometer also. If they're diabetic, check the blood sugar level at that time. Get investigations if we give a history. Otherwise, go ahead and do it and
History is extremely paramount.
Yes.
I would also like to add this: if you have someone 60 plus, if you have someone a senior citizen, please do some basic investigation before this. If you have a healthy young person, you do the history of a tooth extraction, some particular work done. This possibly is what I feel personally, though I don't know how we stand it. Yeah, you want to
So one point, sir. Whether triple H is important or not. So I learned the lesson. What happened was I did a biopsy for a 65. I left for the OT. After half an hour, I got a call from the patient. He said, "Jo apne biopsy kiya, the patient is still bleeding." So I went. I was taking stitches and everything, sir, and still the bleeding was not. I couldn't get hemostresis. I tried my best and everything, and after 20 minutes, her daughter, who's a doctor, told me she's HCV positive. So not only from the universal precaution point of view, we say you have to take it into consideration that everybody may be potential this, but even from the bleeding point of view, because we know that in hepatitis B and hepatitis C, the liver levels are changed and the patient has a tendency to bleed. So in Kokila when we were just discussing whether we should make triple H mandatory for patients who undergo third molar.
Yeah, in hospitals, I think triple H is mandatory,
but not in the
as I said, it's extremely difficult. First, to convince the dentist. Dentist will say to convince the patient is going to be difficult if I'm going to call him again with these blood tests, especially the patient's skin. This is what I feel are the practical difficulties one will face by yeah, so I would say we should discipline the dentist. That's a very nice word. Yes, sir.
No, you think I can hear me? I have some suggestions. See, I have done visiting practice for 4.5 years, first 4.5 years. Then, like all of you who are doing visiting practice, honestly, you will agree with me, but frustrated. Then that time Dr. Kanikapari was my examiner, and he was in general practice for around 20 odd years, and then he started oral surgery practice in his own clinic and stopped complete with general dentistry completely. We're inspired by him. I also started a small oral surgery clinic and stopped general practice, visiting practice. All those who were, can I take 3-4 minutes? Yeah. So, this is what I'm telling you about visiting practice. I wish you also take some courage.
Stop 1 hour session of visiting practice.
No, I take courage and do something. So I started a separate oral surgery clinic, no general dentistry there.
And all those people whom I used to visit, I told them that I'm starting cleaning this and that. 90% of them stopped referring these patients because they said, "No, nahi hai to dusra aayega." So that's another thing, and that's it. That went on, and then I have not done it. My humble request to all visiting oral maxillofacial surgeons is there are a few things I want you to be very strict about. One is take basic history, and if you suspect any health issues, investigate. Secondly, if you operate, please take a proper informed consent. Make the patient sign, and in case you feel that there is likelihood of patient getting numbness on the lower lip during third molar or steady cyst or things like that, underline it, ask the patient to sign, and somebody who is accompanying should also know this. Why I'm telling you this, I'm telling you this, I somehow feel I am not become senior as yet. I still feel I am beginner. But I have grown old. I can't, that is also a fact. So what happens in case of complications, in case of infections, ultimately they go to seniors. Now tell me, you are not a senior. There is an oral surgeon who is in practice for 5 years. There is another practice for 5 years. One doctor has done third molar, and the patient gets numbness on the lower lip, he goes for a second opinion. What do you expect that the first doctor should have? Has he taken a consent? Patient says, I didn't even know that I'm going to get numbness. When he looks at the radiograph, says the roots are very close to it, and you cannot. CBCT is done, everything. The patient was not told. So take a proper consent, see that this will be if you have a proper consent, then you will be able to protect yourself, and your colleague will also be able to protect yourself. So informed consent, proper history, informed consent, investigation, and please see that when you do visiting, the doctor knows, the patient should know who you are and what your name is, and you should please maintain a diary. Wherever you go, I know some of my friends sitting here do 6 visits in a day, and they see 6 patients, they operate 6 cases in a day. Maintain a diary, write name of the patient, you have patient's number, make a small note as to what surgery you have done, because whenever you have a complication, you should have a proper record. Okay? This is about charges. My request is there should be transparency. Decide if you are giving some percentage, give percentage, but if the general surgeon is charging 10,000, you must decide that you will give 30%, you get 7,000. It should not be that. Please stop doing this. You must be firm about your charges. If the doctor is saying that these are 3 patients, you do it free. But if you are charging, and another very important thing, please issue receipts, collect white money, stop collecting black money, because the dental surgeons who call you, they do not, you feel like, he feels very happy that I collected 10,000, I gave this guy 3,000-4,000. You call it 3,000-4,000, you don't show an account, you don't create any history. Then when you go to a bank, you say your income is poor, you don't get a loan. Anyway, I'm stopping.
One last thing, I know for this topic we had said that. The only thing, one more thing I feel I add is make sure your dental clinics have some level of sterilization. Please have dental clinics who do any kind of, absolutely many clinics don't believe in any kind of, so please make sure that you follow some basic principle of sterilization. I think that's as far as visiting practice. Let's stop this topic here. One last topic which I want to talk about is
medical recurring dental surgeon by Paul. Yeah. And there are all consent not decades.
I just want to ask one small thing. In case of a visiting practice, since you have no records of who has done what, the liability of anything going wrong, does it come on an oral surgeon or it goes on a dentist?
Yeah, but the dentist is going to lose the dentist.
You are going to lose the dentist. That's a different story.
But I don't think that's the right approach.
I think this is just from that.
Yeah, I think oral basis, I think Pranay is studying law. That's a different story. Pranay has studied law, so he can be able to.
I just want technical. Pranay, you say
when there is a complication, the dental surgeon will immediately volunteer and say, "Arey doctor, go aaya." Please get strict about how you work.
Yeah. So there's something known as vicious liability, where even if a doctor in a hospital gets sued, the hospital automatically becomes liable as well as the surgeon. Similarly, when you are doing a consulting practice in a dental setup, you are definitely liable along with the dentist who is referred. The owner is always liable for the patient. That's the first law.
Yeah, it's in a hospital. You have a consent which you have signed as a doctor. So you are liable, hospital is liable. Both of us are liable. When you go to a clinic, patient has come to your clinic, you're not taken a consent, you have a ghost surgeon there. At the end of it, something happens and you morally, as doctor you said, morally it's wrong, ethically it is wrong. But purely from a medical legal standpoint of view, probably will you be sued in the court? You can't. Like there is no written document that you are involved.
Unless you deny that I have not done this.
Yeah, that's what I'm saying. I'm denying that I didn't go to the
If you deny that you have not done the surgery,
patient verbally saying doesn't have any meaning at all.
That's my meaning. So you are liable.
if you have audited the case, you are liable for that.
Yeah, if you want, one wants to, false lies and I have out, that's fine. Otherwise, you are definitely liable. I feel if you create a complication, we should be able to stand up for that. We have. Yes, you wanted to say okay, so as far as is there other lines? I finished my yes. So one more last thing which a lot of young maxillofacial told me was yeah, now you have a lot of maxillofacial venturing into other things, like hair transplants. With onco, a lot of people are doing it. There is a lot of resistance which guys have from the general onco surgery, especially, they have been so how many of you really face? I think I would want to ask this to Rishi because Rishi has a good amount of onco and he's been working around a lot of onco surgery in Kokila. So do you really face this resistance? What people have talked about? We have so many of you here. Somit is here, Amit is here, Sagar is here, Sudhir is here. Yes, Amit is here. So many of them. Do you really face this resistance? And if it is, how do you overcome it? Just as an example to the younger maxtrax.
Specifically for people who are planning for a fellowship, I still remember my interview question when I was getting grilled by the CEO of the hospital. One question they asked me distinctly is, what can you offer this hospital which others can't? So if you are going in for oral oncology, your CV is going to be put up, against surgical DNBs and surgical MCH. So you take a call where you're going to stand. If you're going to say trauma, plastics, overshadow. In the corporate setting at least. So I would say please avoid the gray areas, where you overlap with your colleagues. Just go for branches which are still where you can offer more diverse services to the corporate. In my opinion, at this point of time, it would probably be orthodontic surgery, which would get you your recognition, or maybe TMs. But please avoid the fellowships. People they come, they talk to me, sir, onco fellowship karna hai. How is it going to benefit? So please take up something which you
like to add.
Actually, what I've noticed is nowadays everyone is running behind maxillofacial surgery per se. But we should not leave our dental surgeries because one day my wife just asked me a question after a long day surgery. How much did you earn today? I said, this much. He said, I just put 2 implants today. So putting a 2 implant would give you sometimes more than what you do a long hour surgery. But my wife is on. Though we are running away from the dental surgery, we shouldn't run away from dental. Of course, master your maxillofacial surgery as well along with your dental. That will definitely help us enhance our skills and other things.
Yeah. You want to add something?
Yes, sir. Yes, when it comes to oncology, I think probably the situation 10, 15 years down the line was different. Because maxillofacial surgeons handling oral malignancy cases or maybe operating neck, that concept was not in the mind of the other surgeons, general surgeons or maybe ENT surgeons. But what you have seen gradually over the period of time is the institutes like Tata Memorial Hospital or the bigger centers have started offering fellowships for maxillofacial surgeons per se, only for the maxillofacial surgeons. That has happened throughout India. I think few institutes in South also are offering that. So that is a good sign that they recognize that maxillofacial surgeons are competent enough to operate oral malignancy cases as well.
Yeah. Yeah, that's fine. Mine is not about the competency at all. I'm sure maxillofacial do an equally or maybe a better competent job than none. This is how do you, for a young max packs, how do you deal with all the resistance? Sandra, you can comment on this. How do you deal with all the resistance from general onco, from guys who have been MCH, Tata trained onco who have spent years, vis-a-vis you having an MDS and a fellowship possibly in max packs? So I'm not worried about competency. You are all extremely competent. I'm quite confident about that. I'm saying, how do you overcome the resistance?
Sir, you are not going to get a equal regardless of whatever specialty you come in. Once you are a fresher, basically you need to have a good training. You should be able to manage complications as well, not just the technical know how do you do the surgery. And you require time for sure. It is not going to be a cakewalk for sure. So I believe that as Sandesh has already told, because he comes from the same institute where I'm training from. So it is just time, and you just need to show your skill set, and you should be thorough with the subject. That is what I do.
Is working as a team beneficial in such a case where you possibly team yourself with another person of a different specialty who is also interested in oral oncology? Is it beneficial to both, or you feel you prefer
teamwork? I don't know why there is so much hesitation for teamwork, because all the other specialty in a hospital, they always, majority of them, they are working. So if you have a colleague maybe from ENT background or maybe from general surgical background, they also appreciate that you are better at doing what you do, and it is always safer to work in a team. That does not take away anything from.
Right.
So actually, yeah. So I feel that one should not have any hesitation working in a team, and that protects you and the other person also.
Yeah, so if I were to sum it up, it is one, your training should be good. You should be confident of doing it yourself. You should have a good teamwork who will help you go through the entire thing, and you have to be patient for actually when you start off. Yes. Yes, sir.
Sir, what I personally is oral oncology. I understand that even the medical fraternity, they understand that it is a part of it. So where we are stuck is हम अटके पड़े हैं sir. हमको हमारी मेडिकल लगी पड़ी है.
So present from our specialty itself. Actually, the dentists have no my experience that I do get a lot of referrals from dental practice for oral medicine. Okay. I get that.
So possibly our training at the BDS level should be more that the dentists whom we train at BDS should actually know that we are the guys. How they know that trauma is possibly done by dentists send a trauma patient to a maxillofacial, not to plastic. So that's possibly one more way of.
So
I didn't get your point, Dr. Panago. You're saying same thing. What you're saying?
He's talking about something resistance from inside out. You mentioned about a resistance from the other faculties.
Yeah.
I think oncology is last 2 decades.
You are saying for cosmetic is.
Yeah. So last 2 decades, it has been a part of our faculty. It's a part of our curriculum now. I think everybody knows that onco is a part of maxillofacial. So the resistance which the new generation is going to be facing is basically.
Yeah. So now coming to what you speak about cosmetology and specifically, I don't think oral cosmetology is.
No, I am not talking about oral cosmetology.
Question is of hair transplant, very
lot of things which I mean, I have been traveling and seeing a lot of maxillofacial wonders. I mean, why not in our country? I have been
Fine.
What I was just trying to ask is like, why they are so laid back? I mean, I have seen so many people in all different countries like maxillofacial doing wonders in aesthetic surgeries.
So there's a reason for that. We have people like Samit, we have Rishi, we have Sagar. I guess to counter the resistance, we need to become the resistance. That's what we need to do. We need to be together and we need to be the resistance. We don't need to counter anything.
When we passed out, there was a big debate whether maxillofacial do onco or not do onco. Exactly. Now the debate is yes. Because our seniors like them have done the job and made easier for us to enter.
So, but see, people have become very degree oriented now. Earlier, we had people who used to trust you and walk into your door, but now they're reading your CV, they're reading your degrees. That's number one. Number two, a corporate will never entertain an oral oncologist. They want a head and neck surgical oncologist. Exactly. I can't do exclusive work that I don't watch up for thyroids and larynx. I only go for oral oncology cases. The corporate wants a person who can hold the fort in many ways, not just exclusive.
I think we have, in terms of patient awareness also is very important because the patient should exclusively come and ask the corporate, I want this to be done by a maxillofacial surgeon. Then it would be.
Yeah.
Regarding what of entering corporates, why focus only on corporates? My question is, corporates already has a rule that you should have minimum 5 years of experience to become a junior consultant, right? So don't enter corporates. You have other options, other hospitals, and once you have a name, once you build your name, you will be able to do. And there is one more thing what he says about degree, that you should have on paper, you have some training, then only they will allow. So nowadays even Wokhad allows, other hospitals allow. If you have a fellowship, they will allow. But again, it's on experience. So don't focus on corporates, you can go for other hospitals.
Yeah, my only suggestion to this is that when you do major maxillofacial surgery, don't focus on corporates is fine, but do not go to a small nursing home which is in a hospital. Especially the guys who do onco, make sure you have basic facilities for this patient. If he requires ICU backup, if he requires all other consultants to have a look, you should have a center. So it may not be a corporate hospital, but you're a hospital which is extremely well equipped, not a small nursing home having 2 beds and the boy is not working properly. Please don't do that. That's one more suggestion I have. Yes.
I have only one question for head and neck oncologist.
Yeah.
Since head and neck includes thyroid and larynx, where do we stand from a medical legal viewpoint as oral maxillofacial surgeons without a medical qualification? Because all head and neck surgeons are doing that.
Sir, as a part of the training, you will get to operate cases, you will have to operate during your educational courses for fellowship. But then things should be clear, because if I do a thyroid, I'm definitely not going to be medical legally protected. And there is no heroism in surgery. That is what I've learned from W sir. That as long as you are doing oral cavity cancer, I think you are well protected. Doing larynx and thyroid, absolutely you are not protected. Absolutely.
We got so many tools. Yeah. He's also extremely.
Well, I mean, sir, yeah, I agree with Sagar sir about that. I have been trained in head neck. When I did my fellowship, that was a head and neck oncology from US, and I did my thyroid and parathyroid also. But the question is knowing the domain. I have a very good friend from the ENT background as well. I know if there is a larynx cancer, I know how to diagnose that, I can stage it, but I'm not going to do it, even if I am trained in it. So the more we are within our domains, we know what we should do and what we should not, then there is no clash. In terms of corporates getting a head neck oncologist, they always ask for a surgical oncologist also because they only want to get the money. A surgical oncologist has a clash with the ENTs and the head neck people, and the head neck ENTs have the problem with the maxillofacial. But it is all about knowing one's domain. So
What you rightly said is if you don't enter to someone else's domain, you can give the larynx to an ENT guy who's in onco. I'm sure the next oral onco will call you or he'll take your reference. That's how your practice is. What I
yes, sir, because my teacher has taught me parotid, and he still loves that. Okay, I have taught you parotid, and I do parotid. But the thing is that we know that when we have to give the larynx to somebody else, and medical knowledge, sir, I think that it is more important to have a critical care knowledge for a patient in the ICU care, because you have to see the patient's follow-up till the patient is discharged. Even a medical student, the critical care is not taught during the medical or in the medicine. It is something that it is sub-specialized DM subject now, critical care. So I have learned more of it during my times because I think it is very important to manage the patient in the post-op than doing the surgery, even if it's an oral onco case or it is a thyroid. That is how it is important. Besides, I know that medicine is also important.
I think the last topic of what Dr. Panda touched, and I think was cosmetic or aesthetic soft tissue procedure or hair transplant. We really are qualified to do it. Are we protected by rule of law? And fortunately for us, there is no particular this of whose domain is hair transplant. But when we go and see someone, we have a lot of people saying, "Oh, he's a dentist with hair transplant." So, or maybe some other work. So, as far as aesthetic work on the face goes, I think there is no question that we are fully qualified to do it. About hair transplant, I don't know whether the dental council has given a. You will be able to explain that better, Dr. Panda, than what I know. Whether they have really given a go ahead.
Actually,
oyster stands grey.
I mean, it's in nobody's and nobody, even the Raman doesn't have the issue. And it's mentioned in their syllabus as well. It's not mentioned in their syllabus as well. So I mean, it's in a gray zone. So since that we are supposed to be doing drafting procedures and also it could be spoken about a draft.
Yeah. Because when things are fine, it's okay. When things go wrong, is really the problem when you require the support of. And I know this because when I was president, we had a couple of cases filed against people where they actually looked up to the association and we could not, give them help. Proper help is because it's still gray. We still don't know whether what the council. Actually, this was a year ago. What the council's stand is. The Dental Council really supports us to.
What I personally, what I remember, 25 years back, even onco was not in the syllabus of maxillofacial surgery. So that was picked up by a lot of good people, our seniors, and that is how today the young generation are doing happily, and they can kind of say that okay, my onco is my territory. If one of us, not one of us, most of us don't do that. Our next generation is going to be, looking at us and
Let's
saying,
hopeful that we get a change in the syllabus of.
Just one last thing. I raised this in the national thing also. Why do we still not, the association is not pushing for difficult impactions, or if matter impactions done in hospital to become under the insurance thing? This is the one thing which can change the whole life of an oral surgeon. I can tell you this because hospital wants money. If an oral surgeon is getting patient to the hospital, it's through insurance. Now 90% of the surgical practice, to remove a catheter, they take to OT and the insurance covers. We do a lot of difficult impactions. Frankly speaking, some of them are like difficult than any major surgeries, like sometimes. And you don't get any money out of it, the hospital doesn't pay, the insurance doesn't pay, and you don't plan. This is the same thing which I raised in the national conference. So at that time they said we'll look into it. We have to aggressively pursue if you want our future generation to be secure, especially in the financial, because this can change. Your 90% practice, if it gets money to the hospital and the insurance covers, that is the only way hospitals will recognize. They will give you attachments.
They have moved a step forward, if I'm mistaken. And I think I hope, unfortunately, Dr. Gokul is not yet correct. But when I was here, they had put it up to the. But all these things, insurance companies are also very smart. They're not the ones who immediately say the minute they know, and they somehow club it with dental procedures. So even now, when you do a regional assist in the mandible, we make sure that even if you remove a tooth, we don't mention that you remove it. That it gets cancelled and
that's what I'm saying. I'm very cautious in how I rate my paper for a cyst patient.
Yes,
I actually ask my patient and then start building up stories. Why should we do? The same thing written by an ENT gets a thing done.
Insurance is managed by IRDA. When we approach them, it is for our benefit. Insurance is for general public's benefit. Somebody from general public has to fight that. Opthel as a society had fought for that to include that. That battle has taken 13 years in court. So it's for it. I have one more question: is that are we allowed legally or protected to do fat grafting?
Which part of what?
Yes. Yes, but harvesting
harvesting is of course it's enough. Benefit of harvesting is enough.
harvesting of fat is something
So legally
it's not mentioned. That is what it's trying to say.
So legally we are protected by the
I really I don't know, but I think if you can really make an inject before and we can that is much smaller.
So the legality comes that it should be mentioned in the curriculum. So that's so boards refer to curriculum and the goals.
Yes. Yes.
See, there are just two quick suggestions. I'm very much with you guys about the medical legal aspect. I told Sagar long back when Sagar worked with me and my other colleagues were doing onco. Things are not clear medical legally. My earnest request is please involve medically qualified colleagues in your team. We have been doing India bone graft for the last 30-40 years. I always involved in orthopedic surgery when I did it. We took out the graft, we fixed everything, Mukul and Jay, all of it. But we involved one orthopedic surgeon in the team that he was there. So when you are doing onco, I think you should involve a medical colleague in your team. It will protect you. You can do many cases of many more years instead of worry. And I'm all for this insurance thing. I myself have put in some effort. I made 5 guys from you who will work with me. And I tell you, let us push this forward. There are procedures are covered by insurance, and we don't have to tell lies. But when you take out a cyst, then you say, you don't mention the removal of tooth and all that. So I really need your somebody, some people, and I want to work on this.
Honest request, thank you. Members of the association, yeah, honest request the member who is in a position for the association to fight. We as an individual can't fight. It has to be
On a serious note, please inform me. And generally, a lot of youngsters will be willing to work for this insurance, and we need not look up to the national body also as a Maharashtra body itself. We are not going stronger and stronger. I think we'll have to stop this discussion.
Sir, I would like to add in one thing. Not every insurance is denying the dental work or the cyst. Corporate is allowing. So if corporate can get the insurance, the other insurance is also.
Yeah. Yes. So I think we should stop here. I want one final word from Chitra sir. Yes, sir. Of all this discussion, challenges of young maxillofacial surgeons, challenges of senior maxillofacial surgeons. We can talk. Please, we can sum it up, sir.
I would like to thank the organizers of today's function who have revived the study group. Now, there are very few people who are sitting here. Most of them are oral surgeons. But study group has been started by me and Dr. David. Nothing new. Don't call me Ashok. The reason is very simple. There was a situation which I told in detail during the national conference, annual conference at Bangalore. And I was asked to talk something about the association. I am a founder member. And when I started talking, I spoke for at least half an hour, but I got questions which I have to answer for 2 hours. Because nobody knew what is what. Here now, what we did was that I was a professor and head of the department at Dental at Amber, who started the study club, and Ashok gave me an excellent support. And because of that support, the study group came into the picture, and because of that, the study group became the association. There wouldn't have been an association at all till the study group was there. So I want to thank this man. I thanked him many times, no doubt. So I would like to thank that you have revived the study group, and I expect and I would wait for meetings of this group again and again, if not again and again, at least once in a year. You can. Now, one thing I want to say, I am an oral maxillofacial surgeon from top to bottom. I have never done general practice. I have done exclusively oral and maxillofacial surgery. As a matter of fact, many of my patients get angry with me, asking me to do fillings, root canal, and gingivectomy, and which I said no. I send the patients to the dental surgeons or to the person who does the work. The idea is very simple. What I am trying to come to is that if you want to be successful oral surgeon, you must do only oral surgery and not dentistry at all. The moment you start doing other things, you do other things only. If you want to become an oral surgeon, be an oral surgeon in your dream, during the day, during the night, during the afternoon, during the evening. There are only few oral surgeons who practice in the night. Not that I made a good joke. He is my man. He is my man. So, it's not nice to see a friendship, sir. A very simple thing. It's very simple. If you want to become oral surgeon, really, all this talking here has got no meaning. As I told you, I get patients. I will tell you one example. A girl, 8 years old girl, I was in Bombay hospital, sat in the chair, and mother said that Dr. Chitra, you have to see her. I said, okay. Then he said, nobody else will see except you. No, I said, why she is threatening me or something like that? My father has told me that Dr. Chitra only should see. So why? He had a jaw fracture which you treated. I got my wisdom teeth removed by you. And my mother has told me that you have to go only to him. I said, okay, you are sitting in a chair, I'm going to see. But no, you promised that you are going to see. Such type of things happen. They don't want to go to anybody. You are talking about patients coming to general dentist. All these things are depending on. I was talking in here. Hello. Anyhow, the point is very simple, very small number are here, and most of our oral surgeons, and they will understand. So, if you want to become oral surgeon, you have to be an oral surgeon during the day and night and whatever.
Thank you, sir.
Thank you.
Thank you. I will.
So this is one. This is one. The second thing is, remember, my friends will help me no doubt, but my assistants will not. Some of them they will not. The point is very simple. Oral maxillofacial surgery is the only branch which deals with surgery. And in order to know the surgery, you have to know so many other things from medicine. And that can impress the patient extremely well. I hope you are getting what I am trying to say. It's not the dentistry. Dentistry is something different. So, if you want, she is sitting there. I always tell, some other people come to me from out of Bombay, they want to learn oral surgery. They said that we will stay here, we will work with you for 10 days and then we will go. I said, don't come at all. You have to work with me for a minimum of 6 months, see different types of cases, and then only you will learn something, not that you will learn everything. There are so many people who are my students, and if you want to become oral surgeon, you become oral surgeon. But then don't expect. One point is there. An oral surgeon doesn't earn from the first day. He may not earn for 1 week also, 1 month also. But you have to accept that that is because you want to become oral surgeon. I said one of the disadvantages that oral surgeons doesn't not from the first time made the statement. After I made the statement, I also said not for 1 day, for 1 week, for 1 year also.
Yes,
But looking at him, it doesn't look like that. This is really an oral surgeon.
Thank you, sir. Thank you so much. I think we should stop the session here. Thank you for your kind words. And I want to felicitate and thank all our panelists.
Thank you to all the panelists. It's been a wonderful session and this can go on for the whole day, I'm sure. So, Chitra sir, Sakshi sir, please. Dr. Ashok Tagin. Sir, पुढे आहे. Sir, secretary. Not more maybe conversation
I request all of you to let express your please.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Small line of vote of thanks. Also, thank you all. Dr. Yogesh Dr. A.P. Chitresh, great of influence so far, and Dr. Nancy. And Dr. Kalsi. Thank you, sir. We all know there is dinner and drinks served at the stadium, small walks to the campus, or if you go from outside and play ball at the stadium. A vote of thanks. Thanks to all of you first for coming in such a large number for this meeting. Special thanks to all the senior faculty, Daniel Madam, Michael sir, Dr. Asrani, Abu Manwar, Mr. Thank you so much. Give us time. So I must make a note of Shivani Madam, who have been kind enough and gracious enough to give this auditorium absolutely free of cost, and the IPL venue of the stadium absolutely free of cost. Big thanks to our team, Gaurav Mistry, Dr. Yogesh, who really yes.
All oral
So all the chairpersons, all the speakers, thank you so much for sponsors for your and actually you're doing an excellent job of please and all the interns, I must get interns and the coordinators today. Thank you so much. That was as vigorous and helpful as possible. Thank you. Next time, in October, I will request all of you to stand up for the national anthem and then you
पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे